Meeting will come to order. This is the Subcommittee on the Wyoming Department of Health and Budget, and is our custom. We will start with a pledge and a prayer. And Senator Larson, would you please lead us in the pledge?
Pledge allegiance to the flag of the United States of America, to the republic for which it stands, one nation under God, indivisible, and with liberty and justice.
And let's pray. Thank you, Lord, for the opportunity to serve the people of this great state. We ask that you would be with us, that you would give us wisdom and grace as we accept the magnitude and the gravity of that task that we're trying to overtake here. But we ask your blessing on that task and on those that are here. Thank you for being with us. Amen. You may be seated. Mr. Crosland, would you call the roll, please? Try not to take too long.
Mr. Chairman, I will take the roll if that is acceptable. This is for the Wyoming Subcommittee on the Wyoming Department of Health budget, September 30th. Senator Larson,
Here.
Representative Sherwood,
Here.
Chairman Pendergraph.
Here.
Chairman, you have a quorum.
Thank you. Very pleasant good morning to all of you. It's good to see you. And I trust that more will wander in as we get past the boring stuff. But have a couple of remarks that I need to do, some of the formalities and some of it kind of personal. Wyoming is headed toward an impending fiscal cliff. That is caused by what I believe is unsustainable spending. We just bit off more than we really can chew. And I think that we need to take a good hard look at that. It's projected by the LSO that we'll be upside down within about 1 to 3 years. And so the reality is that we need to look at everything. We need to understand what it does, who it affects, and all of those things so that we can do the very best that we can for the people of this state. As appropriators, and indeed as House representatives especially, we are the keepers of the purse strings. And so we constantly have to ask ourselves, is this the proper role of government? Because it sure is easy when you've got loads of money at your disposal to say, yeah, we could do that, we could do that, we could do that. And the question that needs to come up at times, yes, but should we? And I think maybe one of the cruelest things of all is to make a commitment and say, we as a body, as a state, are going to do this, and then not be able to follow through. And so I would rather not make a promise and surprise somebody on occasion than make a promise that I can't keep. So we are not here to slash and burn. We're not here to try to disrupt anything. We are here today for two primary purposes. One is to learn, to be able to better understand how this budget works. We as part-time legislators, this is a big chunk. And you guys do this day in and day out all day long. So it's hard for us to play catch up. And yet that's our responsibility. We are called to do this. I have a copy, and I think it appropriate. It was also the chairman of the House Appropriations thought it was appropriate to read the motion that caused this subcommittee to come into existence. I will remind you that we were at a meeting, I believe it was August 20th, and the subject of DD waivers came up, and the Department of Health was asking for additional funds to be able to get rid of the waiting list and then to adequately pay the providers for that. And many of you will remember that I got up and spoke in favor of the DD waiver program, but I said, we don't have any more money. So we're just going to have to try to look through the budget and see what we can find. I'm not saying we'll find it all. I'm not saying what we'll find. I don't know. That's why we're doing this. But the motion essentially says, the Wyoming Department of Health has a larger general fund. I really don't need this. I've just reached the age where curiosity is greater than vanity. The Wyoming Department of Health has a large general fund biennial budget larger than any other state agency of more than $1 billion. Even modest percentage increases in such a large agency's budget can have significant impact on state and local budget needs. Department of Health budget has an outsized impact on the Wyoming's total budget. Therefore, if we have a budget issue, we have to look at everybody. We can't have any, I don't want to use that term. We have to look at everybody. The committee has expressed interest in supporting specific initiatives such as the waiting list of persons with developmental disabilities and desires to find the necessary funds for implementation within the current Department of Health budget. Therefore, continued aggressive legislative oversight and attention is warranted. And I put the emphasis more on the attention. We need to know what's happening and why and what it affects. Therefore, the motion was made that JAC create this subcommittee consisting of the people that are here. And that's why we're here. Our goal is, the purpose of this subcommittee is to provide a well-reasoned recommendation for the JAC to properly position the Wyoming Department of Health for long-term success. So that's why we're here. As for today, because we as legislators have pretty much constant contact with most of the folks that are in this room, I'm going to ask you to be brief. We can get back with you and ask questions and dig into things offline or at another time. We do want to hear from the public. We want to give them every opportunity that we can. So we have this meeting. We'll have another meeting at the end of our task, and again, invite more. So, and if you do give testimony to those in the public as well, if possible, please refer to the unit numbers in accordance with our agenda. That helps us to categorize exactly what we're talking about and the effects that are there. The last thing is basically a formality, but I'll go through it very quickly so that nobody can say I didn't do my job. Very quickly. Our meetings are open to discussion of all viewpoints, and the rules and decorum are in place to ensure everyone can express their opinions free from abusive or distracting behavior. I would invite you to take a moment to read through the listed decorum rules, but I will highlight just a few. Although it may seem an awkward formality, speakers will address their comments and questions to the chairman, not to individual committee members or to others in attendance. This helps avoid personalities and comments of a personal nature. Comments will be directed to the issue under discussion by the committee. Distracting comments on unrelated side issues are out of order. Speakers will avoid personal criticism, ridicule, or name calling directed at anyone else in attendance of the meeting. This includes comments of a personal nature directed at other speakers, audience members, or members of the committee. For audience members, we expect you to refrain from any behavior that disrupts the orderly conduct of the meeting. Specifically, the rules prohibit speaking out when others are talking, carrying on loud, distracting side conversations, shouting and clapping, booing in response to the speaker's comments, of course, unless you want to laugh at one of our jokes. And then it's only considered polite. Our general guideline is simply that everyone conducts themselves in a civil and respectful manner at all times during the meeting. And I know that we will do this and much more. Thank you for your rapt attention. To my cohorts, have either of you any comments? Brevity is the soul of wit, I heard once. With that, then, we will move on to our 8:15 agenda item, which is the introduction and the overview. And I see you gentlemen are here, and we're going to switch those, or you want to go from there?
Mr. Chairman, if it's acceptable, I'd like to go first so I can defer as much time as possible to the Department of Health. My comments should be brief. My name is Elizabeth Martineau. I am a senior fiscal analyst with the Wyoming Legislative Service Office in the Budget Fiscal Division, and I staff primarily the Joint Appropriations Committee. In preparation for this meeting, we prepared several documents for you as attachments or as Items 2-01 from LSO. It has one short memo and then several attachments. So I'm going to provide a brief overview of those for your information. In the memo on the first couple of pages, there was some interest in what Medicaid optional services the state has and when those came into being. And so we went ahead and just summarized those for your information. Please note that list is based on legislation, and there are some really important nuances to those services that the Department of Health in later testimony can provide when we get to that portion of discussion. So I defer to them on nuances related to the medical services, Medicaid services. The second section is really the meat of the information that I prepared, and that starts on page 3. There's 4 attachments that will help with your discussions, and we really wanted to provide some historical background and framework for your information. Attachment A is a summary of the department's budget from the 2017-2018 biennium through the 25-26 biennium by unit, and I compiled that also by fund. We'll go through that just real briefly in a moment. Attachment B is a document the department prepared in 2017 for that general session regarding those budget reductions. So we felt it was important to provide a few documents the department has historically provided to give you some context on how they've responded when there have been looks at their budget in greater detail. Attachment C, similarly, is from the 21 general session, and that's when, as some of you remember, we had the step 2 and step 3 reductions, which were quite extensive. So there's a bit of documentation for that. And then finally, attachment D is the most recent budget roadmap that the department provided last session for the Joint Appropriations Committee, those of which who are on the committee are very familiar with those documents. We wanted to provide these 3 documents as context for attachment A. And attachment A is something that I compiled on budget requests, legislation, as well as the department's insights, websites, and materials. In attachment A, starting on page 1, it's a table, just an 11-page table that outlines the division in the unit, a description of that unit, and then historic funding for that unit by general fund, federal fund, or other fund in total. I would say just to keep in mind that while we provided this information by unit, there are sometimes several services and programs within a unit. So you might be expecting to see something related to a specific program or service, and if you're not able to find it, that's kind of inherent to the way the budget is set up. So as you know, we budget at the division level in the state of Wyoming, and so we have their budget requests at the unit level, which is what you're seeing here, and then it rolls up into what's in the budget bill, but there is a lot more detail in these programs, which is why the department is here to share those details. I would also note that this is the original legislative appropriation that was adopted in those given years. There is the ability for the agencies to have some flexibility in their expenditures, and so they're able to move money, and this is all within legislative authorization. It's not outside of a process that's already been established, which as JAC members you are aware of. It's called the B11 process for those who are not. They're able to, within very limited parameters, move some money around. And so when you look at what the department may present, just please bear that in mind, that what I have provided you is the original legislative appropriation by unit. They might have moved funding depending on a need or a service or something that has come up, and that is authorization that they have received from the legislature to do those in very limited and targeted instances. Something else about attachment A that I wanted to bring to your attention is that the department's budget is, as you said, Mr. Chairman, quite large, $2.2 billion. But there are some constraints within that budget and that are important to consider when looking at the budget overall. For example, I just wanted to highlight 3 for your kind of keep in the back of your mind during this discussion. There are maintenance of effort requirements throughout the budget. And so again, I defer to the Department of Health on these specific things. I just wanted to highlight kind of ideas, things to keep in mind. So for example, in Unit 2510, which is preschool services, the state has a federal maintenance of effort requirement for that program. And so if you don't meet that maintenance of effort, you could lose those funds. And so if you lose the federal funds, you could lose the program. Additionally, several of these programs have matching requirements. And that one is a bit harder for me to get into because each program, each service has a different match. As an example, traditionally it's 50% state, 50% federal for the Medicaid programs. But as you know, from what we just experienced with the COVID-19 pandemic, there was a bit of fluctuation in that with a higher rate and then it went back down. So there are matching considerations. Similar to maintenance of effort, If you don't maintain the match, you could potentially lose the funds that it is matching. So that is something to keep in mind when looking at those items. Finally, there are non-fund, like general fund sources. So a really good example is Unit 5060, which is the Wyoming retirement home, which is almost entirely paid for by special revenue. So if you were to look at the retirement center or the retirement home, really $284,000 of that is general fund. So it is a much smaller portion of their budget. And there are several other budgets like that, or units like that throughout the Department of Health. I tried to highlight the ones that I could easily identify. They're light gray in the table. Those either have no general fund and are either solely special revenue or federal funds. And Mr. Chairman, with that, I just wanted to provide a highlight of that document as you step through this day and your additional work, so you have that for your information.
Thank you, Ms. Martineau. Director, if you would introduce those that are with you and proceed.
Thank you, Mr. Chairman, and good morning to you and members of the subcommittee. My name is Stefan Johansson. I'm the director for the Wyoming Department of Health. I'm joined to my left by our interim state Medicaid agent, Jesse Springer. He oversees Medicaid in our Division of Healthcare Financing. And to my right is our Chief Financial and Facilities Officer, Eric McVicker. Those of you on JAC probably recognize him from our many budget hearings over the years. So glad to have both of these folks with me. We were asked to prepare an agency overview before the rest of the agenda when it appears we'll go unit by unit. And so we've done that. You should have it in your materials. I'll see if I can share my screen here, although LSO, it looks like sharing is not turned on. That works, thank you. Okay, Mr. Chairman, it looks like the public can fully see the presentation online. So we have a brief agency overview. The purpose of this is really to go over our administrative structure. And then we've done something a little bit different. Since we will, and with this committee, JAC, we always go deep into the details of the budget unit by unit. We thought it would be prudent as an overview, similar to how we presented an overview to the Labor Health Committee earlier this year, to really look more functionally at the department and roll some things up to give the subcommittee and members of the audience and the public here a bit of a macro overview of what the Department of Health does and how it's organized, but also kind of aligning with our strategic plan, a document we also sent you, which is relatively new in the last two and a half years, to really look by core mission and core functions of the Department of Health. And that's how we have designed this overview this morning. So first, with our administrative structure, we, as the Department of Health, we have 4 operating divisions that you can see on your presentation or on the screen here. First, with the Behavioral Health Division, which includes community mental health and substance abuse, early intervention and education, which we affectionately refer to as our developmental preschools. Also has 2 safety net direct care facilities, the Wyoming State Hospital in Evanston, Wyoming, the Wyoming Life Resource Center in Lander, Wyoming. And as we go into the rest of the presentation, we'll hit quite a bit more detail on each of these. Our healthcare financing division, overseen by Mr. Springer to my left here, is really all Medicaid and Kid Care CHIP. But within that structure, we also have sort of specialty programs in the Division of Healthcare Financing, like our home and community-based waivers, which serve folks with developmental and intellectual disabilities, as well as a long-term care population that would qualify for placement and services in a nursing home, but instead are receiving those services in their home and communities. And it also includes our medication donation program, which is a licensed pharmacy that we operate out of Cheyenne and distribute donated medications that come into the state to folks who can't afford those medications, or in certain circumstances to certain types of facilities. So really that program, the medication donation program, lean and mighty, very small program, but does good work in taking what would be thrown away or unused medication, making sure that they're safe, and then being able to redistribute those out at very low or no cost to our communities. Moving on to our public health division, we have our community health section, our health readiness and response section, and our public health sciences section. We'll get into more detail of all things public health later in the presentation, but these services through public health really are things that have been around for a very long time, authorized by statute for the better part of 100 years. So think of infectious disease epidemiology, public health nursing, which we have state and county offices in every county that deliver things like home visitation. They do our long-term care assessments for the Medicaid program, which we call LT 101s. They also deliver immunizations and other healthcare services to their communities directly. Our aging division, our community living section really oversees programming that flows primarily through senior centers throughout Wyoming. So things like congregate nutrition, home delivered meals, activities, really health promotion for our seniors that they can access at our senior centers, as well as some smaller but important programs that deliver services to seniors in their homes as well. So maybe folks who don't qualify for our Medicaid home and community-based services can receive some in-home services to the mission being to delay that institutionalization in nursing homes. But if you, those of you who have been around will know that the Older Americans Act law at the federal level, and those federal funds are primarily what support these programs through senior centers, but there is a small amount of state general funds that go through those programs as well, and then a significant amount of local match or local funding that certain communities provide to their senior centers. So kind of a blended budget for the aging services that flow through those senior centers. In addition, in the aging division, we have 3 24/7 facilities. As Ms. Martineau mentioned, the Wyoming Retirement Center, or what's listed in the budget is the Wyoming Retirement Home. That's a nursing home that the state operates in Basin, Wyoming. Interestingly, it was formerly the tuberculosis sanitarium in many years past, but that is now a skilled nursing facility that is approximately 80 beds in capacity in Basin. And as Ms. Martineau mentioned, years and years ago, I was pretty new here. Eric was relatively new here. We worked with the legislature. The legislature directed us to pursue operating that facility in a revenue neutral manner with no general fund, or as little general fund as possible. And so to date, we have done that. As Ms. Martineau mentioned, there's a very small amount of general fund in that budget, primarily for facility depreciation that would be state costs. But that is generally, that facility is supported by special revenue, which is really from the client. And generally because those clients, many of them qualify for Medicaid. So in another side of the department, the state general funds and federal funds for Medicaid eligibility do support a large amount of that facility's revenue structure.
A couple of questions, if just real quick. As you go through these, I read somewhere in there what the census was, and I'm also curious about how the staffing is. And I know that there's data within what's here, but we kind of could summarize that so the people listening would know. And then the question on the census, these places, I believe some of them have Medicare residents and some have Medicaid residents. If you could elaborate on that slightly as you go to each entity. Thank you.
Mr. Chairman, happy to do that. If it's okay, pretty shortly, within a couple of slides, we'll get to those details, and happy to elaborate or answer questions as we get there. The other two facilities in our aging division is the Veterans Home of Wyoming. That's in Buffalo. That is both assisted living level of care, what in Veterans Administration world they refer to as domiciliary level of care, but it's basically an assisted living facility, formerly known as the Soldier and Sailor's Home in Wyoming. But we also recently, in the past several years, based on legislative direction, constructed and opened a new skilled nursing facility at the Veterans Home. We were the only state in the country that didn't have a skilled nursing facility specifically for veterans. That construction project kicked off, I believe, in 2019, 2020-ish, and we cut the ribbon about 2.5 years ago at the new Veterans Home, and we'll get to some detail on that as well. And last but certainly not least, the Pioneer Home is an assisted living facility in Thermopolis, Wyoming. Smaller by census, about 50-bed capacity. Currently, the census is around 46, 47. And again, we'll get to some detail about all of these facilities shortly. And I wanted to mention on the very right-hand side of the screen, not technically an operating division that delivers direct services, but the major support structure for the agency in the director's office, in my office. We operate our Office of Vital Statistics, which you could consider that a core support function. You could also consider that core public health, given that vital records, vital statistics have really been around for 1,000 years or more. We do all birth certificates, death certificates, divorces, abortion reporting to the legislature. There's a variety of different customer-facing public services that we deliver for being the custodian of record for those vital events. And happy to provide more detail as we get into the presentation there as well. In addition, we operate the Office of Healthcare Licensing and Surveys. This is a regulatory function per state and federal statute, which licenses at the state level a variety of different types of healthcare facilities that statute authorizes. A few examples would be hospitals, nursing homes, assisted living facilities, boarding homes, ambulatory surgical centers. And the state licensure component is really around construction code and life safety code. So that we are the office that enforces the different types of safety standards for different types of healthcare service delivery. And again, that's outlined in state statute. In addition, this office also certifies, surveys, and enforces conditions of participation for Medicare and Medicaid at the federal level. And so kind of on the service delivery side, there are various federal requirements, federal laws that hospitals, nursing homes, different types of facilities must adhere to in order to be a certified provider by the federal government. And so we act on behalf of and as CMS in all of these circumstances. And folks often say, well, why doesn't the federal government just do that directly? And we've had that discussion over the years, and I think it's a real benefit for Wyoming that we have that type of office, because we have Wyoming people that we work very closely. In fact, our licensing and surveys administrator meets very regularly, for example, with all of the nursing home administrators. And anything new that's coming down from the federal level or any standards that might be changing, we try to do our best to communicate those and really help lead to compliance, as opposed to the gotcha on the back end when we survey and potentially have to issue penalties. But that office does have an immense amount of regulatory breadth that really its mission is to try to keep residents who are receiving care in different healthcare settings, both at the state level and the federal level, as safe as possible and correct issues when they arise. And finally, a couple of administrative functions in the director's office. All of our fiscal services, which Mr. McVicker to my right oversees, all of the big budget, all of the expenditures, all of the transfers run out of our fiscal shop for all of these operating divisions and the entire department. And we also have an office, privacy, security, contracts, rules, public records requests, those administrative functions that really just have to happen either directed by state law or the necessity of, getting contracts executed, getting rules promulgated. We have a small staff of about 2 that oversee our process for thousands of contracts, hundreds if not thousands of public records requests, and we are also generally speaking a universally HIPAA covered entity. So Health Insurance Portability and Privacy Act at the federal level. We take our data security and our data sensitivity very seriously at the department, and also adhere to the federal law and are regulated by the Office of Civil Rights on all things privacy and security when it comes to the healthcare information and the protected health information that we have and that we oversee. With that, Mr. Chairman, we'll move as quickly as we can here, but our mission per our strategic plan, and as you see in our budget book for the last several years, is to promote, protect, and enhance the health of all Wyoming residents. And we wanted to outline this presentation. If you move to slide number 4, we've divided this presentation into 4 categories. Really around those functions, as I mentioned in my introductory comments, as opposed to being redundant and walking through the entire budget, which I know we're going to do a lot of on the rest of the agenda and in subsequent meetings with this subcommittee. Those 4 categories that we organize this presentation in are in direct healthcare services, so direct care. Secondly, community services, when we pay community providers or organizations in your communities to deliver medical, long-term care, and other services basically on our behalf. And that's a big part of what the Department of Health does. In addition to the direct care we provide at our facilities, at our public health nursing or WIC offices, we spend a lot of money paying providers for the programs that you all have authorized. And in fact, that's really the vast majority of the Department of Health's budget. In fact, over 90% of the Department of Health's budget goes out the door in the form of payments or reimbursements to various community providers, organizations, nonprofits, small businesses around the state. We'll divide that up in the presentation between Medicaid, behavioral health services, senior centers, and early intervention and education, or what we know as developmental preschools. Third, kind of a new category that we're calling core public health. And as Ms. Martineau mentioned, just like the budget, within these categories, there's, you pick a definition, there's a lot of movement that could happen between these. And so take them with a grain of salt, but hopefully a helpful organizational structure for this presentation. But in core public health, as I was mentioning previously, we do infectious disease research and epidemiology to try to protect the spread of infectious disease. We deliver immunizations. We have a public health laboratory that provides a lot of service to healthcare providers, to law enforcement when it comes to chemical testing, various types of services that run out of our public health lab. As I mentioned before, vital records or vital statistics, and also population health programs like prevention, emergency preparedness also would be considered core public health activities. And last but not least, health and healthcare regulation. So just a few examples here. We license and regulate ambulances through our Office of Emergency Medical Services, or EMS. We operate 24/7 healthcare facilities, so a lot of regulation happens there. And as I was previously mentioning, through our Office of Healthcare Licensing and Surveys, quite a bit of regulation on the state side and the federal side for various healthcare facilities. On slide number 5, Mr. Chairman, we took those 4 functions and added administration, but those 4 functions plus administrative functions, we took the budget and tried to map the budget expenditures in state general funds, federal funds, and other funds, kind of collapsing those categories up. So again, take the budget document. We could go either way, and obviously today we'll go from macro and then get more micro. But we tried to do the reverse here and say, let's take all the micro, the budget units, the object codes, all of those expenditures, and just for the ease of the reader and the public to get a better sense of the Department of Health, roll that up into these categories. So you can see here in administration, we run typically around 5% administration costs in the Department of Health, depending on what you consider administration. So there's a few things here that, for example, non-emergency medical transportation, which is not an insignificant expenditure in Medicaid when we pay for folks' transportation in the Medicaid program. That's actually coded in the budget in our administrative unit, which is included in administrative costs here. But obviously, if you dug into the details, you'd say that should probably be carved out. But for the sake of simplicity, we took a lot of our administrative costs to try to provide you an estimate here. So on the administrative side, when you think of all of our staffing, our systems, the nuts and bolts that aren't direct services or direct care, you can see the administrative top line item there on the first row. In community services, which again includes most of our Medicaid program, our Kid Care CHIP program, community behavioral health services, developmental preschools, this is where you see quite a bit of funding going out the door. And in those services that we'll get into in this presentation, we're over $1.5 billion on the biennium. In direct care, again, that's our 5 state Department of Health facilities, plus our county field offices like public health nursing, women, infants, and children. And you can see the general fund, federal fund, and other fund budget broken out there as well. In those regulatory functions that I mentioned, like the Office of EMS, healthcare licensing and surveys, it's relatively small. We calculate this for this estimate at about 0.3% of the budget, but certainly an important part of what we do. And you can see there just about $2.7 million on the biennium of general funds. And last but certainly not least, on public health, about 3%, a little more than 3% of the overall budget in those core public health services. But again, I want to stress here, there's movement between these categories depending on how you skin the cat. These numbers could change, but wanted to provide kind of an overall estimate. And with that, Mr. Chairman, we won't spend a whole lot of time here, but we did provide a link for you in case the subcommittee is interested. We did develop kind of an interactive visualization that you can access. I'll see if it will work if I pull it up here. Whoops, let's see here. So we won't spend a whole lot of time here, Mr. Chairman, but we like these visuals because the Department of Health is large and complex. So should this subcommittee be interested in digging into some detail, seeing some high-level information, basically what you see here on my screen is a chart that has the entire Department of Health budget. And you can see different colors, different sizes of boxes that generally represent either the size of the overall budget, the percentage of general funds or federal funds within it. But if you hover over them, you can see that if we hover over nursing facility services, what will pop up is the total budget, and then the general fund and other fund breakout, and finally the percentage of federal funds within that. And within each division, you can click on the division and go into even more detail to see the various different budget units, kind of categorized by that unit number. And same kind of thing, if you wanted to see all of our grant and service payments or 600 series in nursing facilities, for example, you can get that breakout and also see the funding. So maybe helpful. We think it is. We try to develop tools that not only we use, but that our decision makers can use as well. If there's something that you're curious about and you want to get a little more detail without flipping to the specific page of the budget book, a tool that's available for you. Mr. Chairman, if I may, we'll get into those 4 categories, starting with our direct care facilities per your questions a few minutes ago. On slide number 8, you can see a map that shows where those 5 facilities are, moving from west to east, starting with our state hospital in Evanston, our Life Resource Center in Lander, the Pioneer Home in Thermopolis, the Retirement Center in Basin, and the Veterans Home in Buffalo. Beginning, Mr. Chairman, with the state hospital, this is a psychiatric hospital, and in fact, the state's only state-run psychiatric hospital. It was established in 1889. It's actually in the Constitution that the Wyoming State Hospital exists in Evanston, Wyoming. We currently have a staffed capacity of 80 beds. The physical plant itself is 104 beds, but due to staffing limitations, we're able currently to operate 80. We've been making progress on filling some of our direct care positions, but a theme you'll hear from me today is a significant challenge across our direct care facilities, especially our safety net facilities with an incredibly challenging population. Entry-level nursing and entry-level CNAs have been very difficult for the Department of Health to recruit. And part of the reason for that is, we're always in small towns, not only competing with the healthcare industry, other hospitals, nursing homes, healthcare providers, but also industry in general. And so if you think of deciding to be a CNA, if you're a CNA at the state hospital, it's also very challenging. There's quite a bit of violent populations, very sick psychiatric populations in those facilities. And so you'll see across all of our facilities, our physical plant capacity and our staffed capacity currently are very different pictures. We're optimistic going forward that we have some solutions to continue to improve that and have some data around that, primarily at the state hospital, where we've seen some success in the past year recruiting entry-level CNAs. But I don't want to candy coat that. It's a real challenge and something that involves both the salaries that the state pays for those types of positions, but also things that are definitely more in our control when it comes to the overall culture, how we support our staff there, how we train, provide education, provide pathways for advancement, and happy to discuss that in more detail as we go forward. So our census currently at the state hospital is 80. And I'll pause here and just mention there's really two sides of the state hospital. There's the civil side, which are folks who have not committed crimes. These are typically coming to the state hospital through Title 25. All of our state hospital patients, with very, very, very few exceptions over the years, all come from court orders in your district and circuit courts around the state through either the Title 25 process on the civil side, or the second part of the state hospital is our forensic or criminal side, and that's generally ordered to the state hospital through Title VII. Those are criminal detainees that have been charged with or have been adjudicated as guilty of a crime and can be committed to the state hospital for either restorative services, essentially to restore them to competency so that they can stand trial for their crimes, or in some cases, folks who are adjudicated not guilty by reason of mental illness and can be ordered to the state hospital on the forensic side of that facility. The budget for the state hospital is approximately $91 million on the biennium. And as I mentioned before, our primary issues are on nurse or nurse-related staffing. And then also with this type of population, some level of difficulty in discharging patients to lower levels of care. For example, when Title 25 patients really no longer meet the criteria or need inpatient psychiatric hospitalization on an involuntary basis, getting them back to their communities with appropriate care can be a significant challenge. And that's generally because our patients at the state hospital have some significant mental health challenges, but also in some cases comorbid physical health or developmental disability challenges as well.
Senator.
Thank you, Mr. Chairman. A question on the 80 beds in the civil side and the criminal side do you have a typical percentage of what those would be?
Mr. Chairman, Senator Larson, good question. So in the 104 bed facility as designed, that's the physical plant writ large. What was designed is approximately 24 beds on the forensic side and the remainder for civil. But I say that with some caveats because the state legislature and the state years ago invested in a comprehensive rebuilding of the state hospital. So this facility, which we're so grateful for, is brand new. And I say brand new, we cut the ribbon in fall of 2020 on the new facility and moved in over the next year. And so we're really housed in one place now. In the previous state hospital, some buildings were 100 years old and then piecemeal there. So there was kind of a wide, disparate campus, and you really had a Title VII wing and then a civil wing. Now we're kind of under one roof. And so we do, Senator Larson, as needed, and based on what we can staff and where the demand or volume is, we will make fluctuations there. Based on our staffing issues right now, we're operating a very limited number of Title VII beds, I believe around 16 to 20 Title VII forensic beds, which is a challenge for our court system. They have long wait times to get into the state hospital. We're doing our best to turn those beds over as much as we can. We're in the midst of some pretty comprehensive reforms that the legislature has directed to reform our community services. We've partnered with the judiciary, the Supreme Court, sheriffs, and law enforcement to make some changes to how care flows into their jails, for example, to try to minimize those issues. But it is a significant challenge both for law enforcement and the courts, hospital emergency departments in some cases, to access the number of beds available at the state hospital.
Had another question myself. I'm pretty familiar with a CNA's responsibility in long-term geriatric care and how intense and what that job is like. And I know that a lot of those are actually individuals that are working toward a nursing degree or trying to get from there. But I look at this particular facility, I think that's got to be a little bit of a different situation. Could you just very briefly enlighten a little bit about the type of people that do the CNAs? What are they working toward?
Mr. Chairman, broadly speaking, these are folks, in my view, that do God's work at a facility like this. This is the day-to-day patient interaction, the overall care, both in terms of CNAs and your nursing staff there. They're providing direct care. They're providing medication. They're providing physical treatment to these patients on a day-to-day basis. And in many cases, these are extremely sick and vulnerable individuals that can be very violent, both on the civil side and the criminal side of the state hospital. And it's a mixed bag to your question on why they come into this particular field and what they're pursuing. In many cases, we have folks who want to pursue that line of work and potentially advance to become an LPN or a registered nurse or study psychology. That certainly happens at our state hospital. In other cases, you have folks that just got into the industry, perhaps worked as a CNA in another facility, nearby and have an interest in mental health or serving mental health populations. And so, Chairman Pendergraft, it really is kind of a mixed bag, but I'd like to take the opportunity there and mention a few things primarily about the state hospital, but really across all of these facilities. You all, a couple of years ago on the JAC and the legislature, authorized the Department of Health about $500,000 to support tuition reimbursement because of this recruitment challenge at our facilities. And that has started to flow to where we can help reimburse, not fully in all cases, but help offset the cost of education for those CNAs who do want to study for their LPN. Prior to that, and currently, something I'm proud of with our Department of Health facilities and especially the state hospital team, we've experimented with and implemented a lot of educational leave, which is a low-cost or no-cost tool that we have in our toolbox to improve recruitment and retention. And essentially what that is that for someone who wants to study for their LPN or their RN, and they're in a program at a community college or a local educational institution, we will pay them as a 40-hour-a-week employee that they will work 20. The remaining 20 is for their school time, for their studies. And that is something that if we can schedule it and shift it, it's no realized cost to the department, but it's essentially an educational benefit we can offer. And then on the back end, we get selfish and say, for that investment that we're making in you, per the time off that we gave you based on your salary, you will work 2 years, 3 years, 4 years, 5 years, whatever that might be for the state hospital in this example, after completion of that degree or certification. And Mr. Chairman, it's been immensely successful. I signed probably 10 educational leave agreements, mostly for CNAs just last week. And it's one of those cultural but also operational elements that really gives folks a sense that there's a pathway in a very challenging field and facility like this, to not only improve their lives, but improve their education. And then on the back end of that, we generally have jobs available for those types of employees that can advance within our system, or quite frankly, after that time expires, be more employable in their community or in their region, in their county, in other industries. And the second thing, Mr. Chairman, that I'll mention, because it comes up a lot, and I understand why it comes up across our facilities, we have a lot of vacant positions in the Department of Health. In fact, 300 or more currently vacant positions. The vast majority of those are at these facilities. And they are vacant because we struggle to recruit them. As an example, we've had psychologist positions at the state hospital that have been posted. We're recruiting them literally for years and have no applications, primarily because psychologists at other facilities or other systems or nearby in Salt Lake are paying quite a bit more than we are at the state hospital. In addition, quite a few vacancies for CNAs and nurses, especially on the entry-level CNAs and entry-level nurses. What we do when we have those vacancies, and this has been a real conundrum for me as the director over the past several years, we could make the decision to say, hey, we cannot recruit these positions. They've been vacant for a year, 2 years, or more. We are going to only staff our facility to the number of positions that we can recruit. Therefore, we have to turn off 10, 15, 20 beds because we can't operate them safely. I have struggled to make that decision and have not made that decision because of what it means for our law enforcement, our sheriff's offices and their jails on the Title VII side, what it means for our court system and our county attorneys on the Title 25 side who have the volume. The orders are coming in. And so what we do with those vacant positions is we take the vacancy savings in the 100 series, and it can't be one-to-one, and I'll get to why. We then contract for essentially agency labor, traveling nurses, traveling CNAs, to keep that minimum amount of beds open. You see here at the state hospital, we have a 104-bed facility. We're operating effectively 80 beds right now. And we're able to do that primarily. The reason we're not operating 60 beds, for example, is because we're contracting for a lot of agency labor, traveling labor. The reason it can't be one-to-one, I would love that if we said, hey, can't hire this state position, let's go buy a temporary nurse or a temporary CNA, is because the premium for that is often 2 times or 3 times what we pay on the state side. So it's a real challenge. It's a real pain point for the department and for me that results in a lot of policy decisions for us that we will certainly discuss with you all, with the JAC, with the legislature more broadly. It has come up this interim with the Judiciary Committee on a few items relating to the courts and relating to Title VII. It has come up with the Labor Health Committee. What we're really trying to do is strike the right balance in not only being fiscally responsible. I do not want to continue to pay $75 to $80 an hour for an entry-level nurse. But right now I can offer $31 to $33 an hour for an entry-level nurse at our facilities. And it's a real challenge to be able to recruit that. So pardon the digression, Mr. Chairman, but wanted to make sure it was clear that generally speaking, that's almost a 100% utilization of our vacancy savings in those positions. I direct Eric to lock all of those funds down. We don't want them being spent on anything else. And in fact, a lot of our unspent funding goes to fund the staffing, labor, and staffing costs at our facilities.
Thank you. Actually, I appreciate you getting into that because I think there's a lot there to chew on. And like I said, we've talked personally before about my background, and maybe there's some things that we can work on there on the side. So we'll have to make up a little bit of time here going through the others, but I think they're basically pretty straightforward.
Mr.
But
Chairman.
I look forward to meeting with you and talking about where that balance is.
Absolutely, Mr. Chairman. And we'll be brief on the remainder of the facilities. Slides 10, 11, and 12 go over our Wyoming Life Resource Center. That's in Lander. Again, a new facility the legislature directed to be rebuilt that we moved into a couple of years ago. We have 2 levels of care there for very significantly disabled, developmentally disabled, and psychiatric clients. Right now, our census is too low. We're working to get that up, but again, those staffing limitations do come into play there. This is a new mission for this facility. In addition to the legacy population that has been served over the decades at this facility, it was remissioned to really be an intermediate care placement for folks who are extremely hard to place. Very difficult conditions, folks discharging from the state hospital, for example, that are in need of long-term care, not psychiatric hospitalization, but more long-term care. So we have a skilled nursing facility and an intermediate care facility level of care at that campus. The budget is approximately $65.6 million on the biennium. The Pioneer Home, Mr. Chairman, again, assisted living facility, about 50 beds. Our census as of August, this is a little bit dated, was 43. I believe we're at 45 or 46 currently. Smaller budget, $5.3 million on the biennium. And we are reliant on a state general fund subsidy there, although over the past several years, we've implemented a lot of revenue offsets in that facility using our Medicaid home and community-based waiver program, our Community Choices waiver program. That funding that comes in to offset the general fund costs of this facility book straight back to the Treasury, to the general fund, unlike the retirement center, which we'll get to next, which has an enterprise revenue account. And that is, again, a skilled nursing facility in Basin. Our staffed capacity is around 90 beds. We're much lower on the census right now at around 76, which isn't necessarily an issue because, again, there's not a general fund subsidy at this campus. But this, in addition to the state hospital and our other facilities, a very, very significant staffing issue here. In fact, currently we are about 70% contract labor at this facility for direct care, which is a big problem, not sustainable. We will work with you guys and are working internally on solutions to that. But as you can imagine, very rural location, difficult to staff at the current wages that we have offered. And
Senator?
Mr. Chairman, can we go back to page 10? On my slide, the staffed capacity, it's not filled in, so I'm not sure if I don't see it up there either.
Mr. Chairman, that's an oversight on my part. Staffed capacity there right now is just over 50, probably 55 or 60. Apologies for the oversight there. And finally, on the facility side, on slide number 14 is the Veterans Home. 13 and 14. The Veterans Home has assisted living facility capacity and skilled nursing facility capacity. On the assisted living side, around 75 beds. Our current census is 58, approximately $7.8 million biennial budget. And again, broken record here, one of our primary issues is reliance on contract labor, both at the assisted living facility and on slide 14, you'll see the skilled nursing facility, which is a 36-bed physical plant. Right now, we have 2 of the 3 cottages full, so our census is 24. We've made the decision to hold off accepting admissions to the third cottage, primarily because right now the way we would do it is through that expensive contract labor mechanism. And so with those 24 beds, we're really focusing there more on recruiting state staff as opposed to filling all 36 beds with this multi-million-dollar cost of contract labor on the back end.
So you've got basically another 12 beds that could come into play if you could staff it.
Mr. Chairman, that's accurate. And in that third cottage, that third 12-bed cottage, that was built to a higher hardened standard for more psychological type issues or behavioral issues. So should we be able to staff that in the near future with lower cost state staff, then a big benefit to the state for those veterans.
I'd just like to point out for the public, when you go into that facility, it's pretty much state of the art. It's very well done. You go into some places and the CNAs are physically in danger and trying to transport and move people. You guys have got cranes and everything else set up there. Pretty nice facility.
Thank you for saying that, Mr. Chairman. Something we're proud of. I know you all have another policy decision coming to you again this year on whether or not the other side of that campus, the assisted living or domiciliary, should be reconstructed. There's a federal grant that's been approved for the construction of that, but the money has not come in, and we don't know when it's going to come in from the federal government. But appreciate you saying that on the skilled nursing component that was completely newly built in the past several years, something I'm very proud of, and the veterans that we've been able to serve there. As you mentioned, when you go into that facility, and I've spoken with them as well, thankful to be there. The environment is great, and I know many of you, if not all of you, have toured that facility, and it's somewhere I would live. It's somewhere I would certainly put any of my family members. So thank you. Okay, we'll move on to slide number 17, direct care public health nursing. So now we're in the direct care bucket. We went from facilities and we're going to go to another type of direct care with public health nursing. This is, we provide nursing services directly in 17 counties, and there are 5 counties that operate independently. So the legislature has a model and statute that the state can operate public health nursing offices in these local communities, or if counties elect, and 5 of them have, can run their public health nursing offices through county employees with a certain amount of state funds that go to support those operations. So instead of staffing them directly at the state level, we essentially transfer that funding to counties who then staff their own offices.
I did go to public school, but when I did, 17 and 5 were 22, and we have 23 counties.
Mr. Chairman, I know there's an answer to that question of why it's 22. This came up at the Labor Health Committee. I'll get that answer when we break and clarify that. But yeah, there is a reason for it. I promise. As I mentioned, primary services through public health nursing, home visitation. That's something the state statute directs us to do, to make contact with every newborn baby and their mother to determine if certain assistance is needed. And our home visitation program operates out of these offices. We have an adult immunization program, communicable disease screening program. As I mentioned before, our public health nurses conduct all of our Medicaid long-term care assessments. And then we have certain amounts of community outreach for various public health benefits as well.
Thank you, Director. Several questions, but I'm only going to ask one at this point. We'll meet later. I believe it was Carmen Rideout, when she was in Sheridan, gave me a study where they had talked about their estimates of what we were able to save by keeping people in their homes longer. If that could be made available to the committee, that would be helpful. I believe I have a copy somewhere, but are you familiar with the type of study, at least? referring to?
Mr. Chairman, yes, there's multiple studies out there on, delayed institutionalization and, home services. This, I just want to clarify on public health home visitation isn't directed at seniors, but at newborn babies. So things, out of our public health nursing offices, you guys might recall plans of safe care, which is recently legislated for potentially babies that are born substance exposed. And so our public health nursing offices work with DFS and hospitals to, provide home visitation and those types of services in essentially when there are, healthcare needs, social needs, impoverished families, et cetera, to set up that new mom and baby for success. But absolutely, we'll get to that a little bit later in the presentation. Moving on, Mr. Chairman, on community services. So our second category that we organize this program, we'll talk about Medicaid. And please feel free, Mr. Chairman, to hurry me along if we want to get to the other parts of the agenda with going through the budget. But I'll be as brief as possible. Medicaid is a joint federal state insurance program that pays for both medical care, an important distinction here, also long-term care for its members. Most commercial health insurance products do not cover things like long-term care, institutional placement, care for the developmental disability type services. Medicaid has programs for both. But I want to point out here that in Wyoming, as we'll get to, you cannot be eligible for Medicaid in Wyoming just by being low income. You have to be low income and meet one of our categorical criteria. So think of your aged, blind, disabled, specialty populations, different clinical or acuity standards that have to be met in addition to being low income qualifies you for Medicaid in Wyoming. We provide, which I won't linger on slide 21, kind of the origins in the Wyoming Constitution for necessary support of the poor, and origins in statute dating back to 1965 in the Social Security Act. Wyoming joined the Medicaid program in 1967 after that was passed.
We do have a question here from Senator Larson.
Mr. Chairman, thank you. At some point, will you talk about work requirement for Medicaid? Is that coming up?
Mr. Chairman, happy to answer that now. So in recent federal legislation through H.R. 1, the One Big Beautiful Bill Act, there were different types of work requirements imposed on state Medicaid programs. Wyoming will not have those because essentially we do not have non-disabled adult populations on our Medicaid program. This is targeted at states who have expanded Medicaid to a non-disabled adult population per the Affordable Care Act, and work requirements over the next 2 years are being imposed on states essentially that have expanded Medicaid. So again, as you'll see on slide number 23, you can see our categories of eligibility in Medicaid, which all have various income or financial standards. But in addition to that, you have our categorical standards that I mentioned. So, children represent the biggest part of Medicaid enrollment that you can see on slide number 23. In fact, over 40,000 of our currently 66,000 enrolled clients are children. So about 2/3, the vast majority of or the majority of Medicaid enrollment is children, both through our Medicaid program and our Kid Care CHIP program. You can see going down that table, you have low-income seniors, very low-income family caretakers. So for our family caretaker, or what we call family care eligibility, that's around 56% of the poverty level to qualify, and you have to take care of, a ward, disabled child or family member, et cetera. And then you'll see our pregnant women category, individuals with intellectual disabilities, and a very small amount of other. We're happy to get into the details here. You'll see that throughout our budget book of the various programs that fit into these categories. Won't linger on slide number 24, but you can see across some of those categories are various income standards and what that means. On the right two columns, you can see the estimated dollar amount for individuals or for a family of three, depending on the type of program. So with children, we cover through Medicaid and CHIP up to a family income of 200% of the federal poverty level. For pregnant women, 154% of the federal poverty level, or about $24,000 a year in income. For low-income caretakers, effectively, I'd mentioned over 50% of the poverty level. Effectively right now, because of those income standards and the change in federal poverty level guidance, we're operating that eligibility at around 41% of the federal poverty level, or approximately $11,000 income for a family of three. And then on nursing home and our community waiver or home and community-based waiver programs, our income standard there is 300% of the SSI standard, which equates to an individual of around $34,000 per year. I'll see if Mr. Springer has anything to add there. If we can move on. He speaks all things Medicaid.
Hello, committee. I'm Jesse Springer. Just on the low-income caretakers, that's going to shrink over time. So it's, even though it's Chairman Pendergraft, it's 41% today. Next year, it might be 40%. The year after, it might be 39% because it's a fixed dollar amount. So when there was welfare reform in the 90s, it converted this group away from traditional welfare to this family care adult program, and it's a fixed dollar amount, so it's been shrinking over time. So, you know, at that time it might have been 100% of the poverty level, but every year now it shrinks because the dollar amount doesn't change, so it just recalculates. So whatever percentage of poverty level. So, you know, you might see this 2 or 3 years from now and say, "Hey, I thought that was 41%." It'll be 38%, or you know, it'll just keep shrinking over time.
Thank you, Jesse. And Mr. Chairman, going back, did through the magic of technology get an answer to your question of why our math was so bad on 17 plus 5 equaling 23. That is because Campbell County operates its own public health nursing office without a contract for the state. So all counties are covered, but the reason that's not part of that total is they are totally independent and without a contract for state support. Yeah. Mr. Chairman, you're right to call me on our various math errors because they do happen from time to time. I wanted to mention, Mr. Chairman, on slide, sometimes the rounding errors, Mr. Chairman, can be in the millions of dollars.
Just, we're sitting up here looking at 2025 poverty guidelines, 48 contiguous states, 2020-25 version. And it gives dollars per month, it gives dollars per year, depending on the chart. That's current. So when they come out with these new ones, do they not change the baseline, or how does that work? Thank you.
Chairman Pendergraft, so if you look at the children, 200% federal poverty level, whatever that federal poverty level published, and we use one that's published by CMS, HHS, but they're very similar. That would reset the poverty level. So you're basically saying this is what poverty is, 100%, 200%. And so those ones that have exact percentages, it moves with that percentage. Low-income caretakers just a little bit special because it's actually established in all of federal statutes as a converted dollar amount. So whatever our actual dollar amount of poverty was at the time of, it was 1996, during that conversion, it's converted as a dollar amount. So we do the calculation for convenience here to show you the percentage of poverty level, but it's actually a fixed dollar amount by family size, and it varies between 43% and 38%. And, you know, if a family size of, you know, it's just a lot more complicated than this type of presentation. And then you also see these SSI standards. So those are someone who is fully disabled on supplemental income. So this is an SSDI, this is SSI. So it's approximately $800 a month. is 100% of the SSI standard. So that standard has also changed over time, but we just adopt whatever that standard is. So as the Social Security Administration changes that standard, if they released a new standard, we would just reference that.
Mr. Chairman, slide 25, just wanted to point out, we do have citizenship and residency requirements for Wyoming Medicaid. Members must be a Wyoming resident and a U.S. citizen or lawful permanent resident who has resided in the U.S. for at least 5 years. Undocumented or ineligible immigrants do not qualify for full Medicaid coverage, but there is a federal requirement to provide certain emergency type services for this population as long as they meet all eligibility requirements. It's very small, but essentially best example that I like to provide is, perhaps an undocumented resident goes to an emergency department and it would be fully uncompensated. There is a small amount of funding that we can provide to the hospital to offset that uncompensated care for that person. But it happens post hoc after the fact. So it's not something that happens live, but wanted to mention that our Medicaid program does have pretty strict citizenship and residency requirements.
Is that fairly rare in Wyoming? And maybe over the last 4 or 5, 6 years, have you seen any kind of a rise in that occasion?
Mr. Chairman, I don't recall seeing a significant increase. I'll defer to Mr. Springer, but we can look into the trends over time. We have all of that in our data. Jesse, anything you want to add there?
Chairman Pendergraph, we don't have more new people, so there are not more people accessing that. They actually have to fit one of these other groups. So, if they're healthy adult, 100% of the poverty level, they don't actually have a category to fit. So even if they're a non-citizen and they're in for emergency services, we wouldn't reimburse for that. So it's generally going to be a pregnant woman or a child that would fit a different group we do cover, then we can cover them for an emergency and a non-citizen. It's about 100 a year. During the pandemic, we were not allowed to disenroll, which was very strange with emergency. So, the people came, they got the emergency. They weren't having an emergency again, so we weren't paying any bills for them, but we were not allowed to disenroll them until 2023. But now that enrollment's dropped back to more normal levels.
Senator Larson.
Yes, Mr. Chairman. Your definition for Wyoming resident is what?
Jesse, go ahead if you know. If you
Chairman
have
Pendergraph, Senator Larson, you have to have a Wyoming physical address. So your mailing address may be, plenty of people in Wyoming actually have mailing addresses not in Wyoming. So it has to be a physical address in Wyoming. If you were a Wyoming resident, but we placed you out of state, we still keep you as a Wyoming resident. So that, like an example of that might be a kid that is sent to a psychiatric residential treatment facility for 6 months. They then come back after, or a person needed nursing home care that we don't have in state. They go there for that term, but they're still Wyoming resident because we just didn't have that care in state. But if that makes sense.
Mr. Chairman, yes, no time requirement or anything.
Mr. Chairman, Senator Larson's, I believe it's 5 years, a resident of Wyoming.
5 years.
Oh, excuse me, resided in the U.S. for the last 5 years. Sorry, Jesse might want to clarify.
So for a U.S. citizen, it would be they have established residency. So it's really a 1 month type requirement.
Thank you.
They just, nobody can be, the way this works is nobody can be a resident of 2 states. So they can't be getting benefits from one state. And, we have people that move between Montana and Wyoming, for instance. They need to establish residency in one. They can't get benefits from 2 states. So we actually have processes to check with all the other states to make sure people are not enrolled in 2 states.
Thank you for the clarification. Please continue.
Thank you, Mr. Chairman. On slide 26, just a visual here of our overall enrollment in Medicaid and the trends over time. So you can see on the bottom of that chart, the different colors represent those different categories: children, pregnant women, adults, SSI, low-income elderly, long-term care, the developmental disability waiver population, and a small category of other. We tried to point out some of the big trends that impacted our Medicaid enrollment over time. So you can see back in 2008, 2009, during the recession, you do see a slight uptick in enrollment. And then you did have in 2013, 2014 timeframe when the Affordable Care Act passed, Wyoming did not expand Medicaid for non-disabled adults, but there were various categories of expansions that were required by federal law. So you see a slight uptick in enrollment there. And then we, at the legislature's direction over the past 7, 8 years, have implemented new systems across the Medicaid program. And at that time, we're implementing a rules-based eligibility system to essentially screen out individuals who should not have been on the roll, should not have been eligible due to various errors or potential oversights in the previous system. And you can see over the subsequent 4 years or so, a pretty significant drop in enrollment. Then in 2020, when the federal government declared a public health emergency during the COVID-19 pandemic, as Mr. Springer mentioned, one of the provisions of federal law and rule that came out was that Medicaid programs were not allowed to disenroll folks from Medicaid during the public health emergency. So you see a significant uptick in enrollment during that time, primarily in, again, where most of our enrollment is, those are children. 2/3 of our Medicaid enrollment are kids. And it was interesting because Wyoming, unlike some other states, we didn't see a whole lot of increased utilization. So it wasn't really a one-to-one where you have, thousands of additional people on the rolls of Medicaid because we can't disenroll them. But that also came with an enhanced federal match rate during that time, as Representative Sherwood mentioned earlier this morning. And that was kind of the tit for tat between states and the federal government, was they were saying you can't disenroll people, but also here's a slight federal match increase during that time period. You can see in 2023, we began what we call the public health emergency unwinding. When those federal requirements went away, we began doing all of the eligibility renewals for that population. And you can see the pretty precipitous drop in enrollment following 2023 to now, getting back to a more stable level of enrollment that you would anticipate prior to the pandemic.
So we are, the clock is moving faster than we are. So I'm going to ask the committee, and I ask myself especially, try to jot down some questions and we can cover them later unless it's something that we really think the public needs to hear. And we'll try to zoom on.
Mr. Chairman, we can skip a couple slides here. We do have some reference material for you on the number of births paid for by Medicaid on slide 27, an overview on slide 28 of the types of benefits that we provide through Medicaid, including medical care, extended medical benefits, and long-term care. Slide number 29 shows our annual state fiscal year expenditures, the average enrollment, and what you'll hear us say a lot is PMPM, or per member per month. That's the monthly per member cost in Medicaid. And this is rolled up from all of our eligibility categories over time. So you can see, again, the overall expenditures on a fiscal year basis, the average enrollment, and the per member per month costs. Similarly, on slide number 30, you can see our overall state fiscal year enrollment on the left pane there. In the middle, our overall expenditures, with dark blue being real and light blue being inflation adjusted. And finally, on the estimated per member per month cost, you can see that both in dark blue on the bottom as our real per member per month cost, and on the light blue on top, the inflation adjusted cost there. It's important to point out on slide 31, these per member per month costs vary by the type of member. So we have a lot of different programs. The big takeaway here that won't surprise anybody, kids are relatively cheap. And kids represent 2/3 of our overall enrollment. So to ensure children, generally not the same type of monthly expenditure that you will see in a nursing home population or your DD population, for example. And you can see the per member per month cost broken out on the right-hand column there. To close out Medicaid, just a few administrative facts. On average, in our Medicaid program, approximately 95% of expenditures go to medical services. We run about 5% administration. So all of our claims processing, basic eligibility systems, et cetera, make up about 4% of our administrative costs. And state employees are a little bit, I believe a little bit less, but around 1% there. So 95% going in the forms of reimbursement. Through our system modernization, through technology improvements over the years, largely thanks to Mr. Springer here to my left and his team, we pay providers in about 3.9 days after a claim is received. So very quick payment processing, and almost all of those claims, virtually all of those claims, are submitted electronically, and virtually all providers are paid through electronic mechanisms. Moving on very quickly, Mr. Chairman, we'll go also in community services, our behavioral health center. So this would be in our behavioral health division. On slide number 35, you can see we have 8 organizations, again, coverage across all of our counties, but 8 essentially entities that provide community behavioral health services under state contracts across Wyoming. The purpose is to provide outpatient and residential behavioral health, substance use, and mental health services to certain priority populations. And those priority populations and the new way that we pay for mental health and substance abuse services results from a comprehensive reform that was both legislated a couple of years ago and that we implemented in July of 2024. So a very important reform that I think is meaningful to the state, where we have prioritized the populations that you see listed there: acutely mentally ill, justice involved, high needs children and their families, and then a low income high needs category as well. The budget for the community behavioral health services is approximately $100 million on the biennium. And you can see that we have that carved up into 3 categories. About half of that is in billable services, or us paying for specific services: counseling, therapy, medication administration. 40 million in fixed payments. So in this system for priority populations, we pay infrastructure payments to those providers, keep the lights on, keep the doors open type payments, and approximately $11 million in grants for billable services as well that run a gamut of different types of things. But for example, we have an outcomes-based payment model for these priority populations that we are testing, where we will provide incentive or bonus payments to providers. For example, someone discharging from corrections or the state hospital, that if they are employed, volunteering, engaged in their community, engaged in their treatment, housed, we will provide an incentive payment to those providers. On the next slide, you'll just see a map of where those behavioral health centers, both mental health and substance abuse or substance abuse only, are located throughout the state. Also in community services on slide 37, early intervention and education. These are our developmental preschools. The purpose of this program, which is a relatively large line item in my budget, is to provide preschool special education and related services to children identified with developmental delays and or disabilities. This runs and is regulated through the Federal Individuals with Disabilities Education Act, or IDEA. We have 2 programs within this overall structure or unit. Part C serves kids birth through age 2, and Part B, which is generally governed through the federal IDEA and Department of Education, serves kids age 3 through 5. As Ms. Martineau mentioned, this is a program that does have a maintenance of effort requirement from the federal government, and you can find the state statute there in Title 21, Chapter 2. The number of children served, you can see on slide 39, approximately 2,200 in Part B, 1,100 in Part C. And on slide 40, just a map there for your reference on the 14 different child development center regions and the 42 locations where these services are provided. Finally, on EIEP, 2 slides on current funding and both state and federal regulations. So this has changed even recently. 2024 session laws really did update a few things, both in how children are counted as eligible and when. So changing the child count date from December 1st to May. And also changing the way that the external cost adjustment, or ECA, in this program is calculated to align more with the K through 12 ECA, or external cost adjustment methodology. Previously, before this legislation, we essentially got the ECA on one inflationary index, and the K through 12 system uses multiple. So per this legislation, now that ECA is calculated using 3 inflationary indices. And so just a few changes that happened over the last couple of years in this program. But the most important slide to close out this area of funding is on 42. Slide number 42, you can see our developmental preschool, or EIEP, funding broken down by our standard budget and also the ECA, the most recent ECA. But what I wanted to point out is you can see the overall amount of state funding, which on an annual basis is around $37 million. And the federal funding that comes into this program is around $3 million. I point this out because you, as decision makers on appropriations, struggle with the same thing we do, that a lot of the federal requirements in a program like this dictate how, including maintenance of effort, how the state must fund a program like this. But the state is contributing, upwards of 80-90% of the funding. So it's a frustrating element for me managing this budget. You'll hear from Eric and I in our budget hearing coming up this December. Once again, we're required by state statute to bring you all of the external cost adjustment requests, and you have the decision in front of you of what to fund, if any of that. But it is challenging because once you appropriate funding in this program, that maintenance of effort kicks in, and the federal government will say you cannot go below that in the future unless there are significant economic conditions that require cuts, et cetera, et cetera. So I wanted to point that out. It's a heavily generally funded program with a lot of both state and federal regulation and restriction behind it, and a relatively large line item in my budget. Moving on to our last 2 categories in community services. Chairman Pendergraft, you had asked about our senior centers earlier in the presentation. We have a network of about 38 senior centers. Won't go into all of the services. I mentioned a few of them, and they're listed there on slide number 44. This is approximately $32 million biennial budget, 10.5 of which are general fund grants to the Wyoming Senior Services Board, or WSSB. 11.4 million of that general fund on a biennial basis is for Wyoming Home Services and various support services delivered through senior centers, and then about 9 million in federal funds that really revolve around various nutrition programs that are delivered through senior centers. And as I mentioned before, federal funds from Title III Older Americans Act are really what govern a lot of this work.
Take a second and acknowledge another representative who has walked in. Representative Connolly out of Johnson County is here. Welcome. Representative Bill Alleman was in briefly and disappeared before I got a chance to acknowledge him, but thanks for being here.
Mr. Chairman, the last category in community services is women, infants.
Sorry, I hate to halt you. Senator Larson.
Yes, thank you, Mr. Chairman. I know we're kind of trying to rush here. The dollar amounts going to these senior centers, is it divided by population or use, or how do you do that?
Mr. Chairman, Senator Larson, it varies. So typically there's formulas that govern the allocation in most of these programs based on population size, but it does vary. For example, in the Wyoming Home Services program that's largely delivered through senior centers, there's a request for application, and that really depends on the capacity that the senior center has, how many people they could serve. So a little bit of a mixed bag there. Mr. Chairman, women, infants, and children, or WIC, is the last category in our community services. section of this presentation, and this is, it funds the purchase of nutritious food for women, infants, and children, basically new moms, new babies. You've probably either been to or heard of your local WIC offices around the state. Things like infant formula is provided to certain types of clients there, in addition to nutrition education, breastfeeding education and promotion, and also that food that can be purchased under pretty strict nutritious standards we have a network of around 75 contracted grocery stores, and the monthly caseload of clients there is around 7,900. You can see the staffing and the budget breakdown on the last two bullet points. Now we'll move on, Mr. Chairman.
Very briefly.
Sure.
I see 4 million in other funds. Are those grants, or what type of funds are those?
Mr. Chairman, I'd have to defer to our CFO if he knows off the top of his head, or we can get that information. Not sure if it's special revenue or. Mr. Chairman, could be tobacco settlement funds, but we'll get back to you on that. Moving on to core public health, Mr. Chairman, we'll start on slide 48 with epidemiology. So the purpose here is infectious and chronic disease surveillance and case investigations. So think of things like, measles, whooping cough, COVID-19 years ago was part of this work. We have about 5,000 cases reported annually, approximately 8 to 16 outbreak investigations annually. And this unit also oversees what we call our BRFIS, or Behavioral Risk Factor Surveillance System survey. That's a regular survey that happens to survey people's, healthcare conditions, healthcare needs, those types of things. Large population health data that's provided and managed out of this program. We have 8 full-time employees, 7 AWACS, a budget of just over $1 million general fund, and 2.9 million federal funds. Slide 49 is our maternal and child health unit. Purpose for this unit is to lower the incidence of preventable death and disease in mothers and children. Focus areas here are women and infant health, children with special health care needs, the youth and young adult health program, and maternal and child health epidemiology. Have about 11 staff, largely supported with federal funds and other funds, but approximately $1 million in general fund in this unit. On immunization, slide 50, we subsidize doses and oversee mandatory immunizations for children enrolling in school and childcare facilities. Approximately 8 full-time employees in this immunizations unit with a $7 million biennial budget. About half of that is general fund. And in terms of the publicly provided doses of various vaccines, measles, mumps, rubella, varicella, a lot of different vaccines that can be provided by this program. Approximately 74,000 doses shipped. Coverage rate, we have the 7 vaccine series for 19 to 30 month olds. And you can see our kindergarten entry percentage there as well. Also in core public health on slide 51, the Wyoming Public Health Laboratory would encourage any of you who haven't been to our public health laboratory in Cheyenne to go and see it. It's an impressive place, kind of a lean and mighty shop. We do a lot there, and we're very advanced on the scientific side of the public health lab, led by Dr. Joseph Reed. The purpose for the laboratory, we have 2 macro functions: chemical and microbiological testing and confirmation. On the chemical testing side, as I mentioned before, we serve a lot of entities through that, including law enforcement for chemical testing, urinalysis, and different types of criminal cases to test for various types of substances, drugs, et cetera. We also serve Department of Family Services in different types of chemical testing. And then also in microbiology, we do a lot to surveil and test, all kinds of things for public safety and public health, including just as a random example, if a public office like a county court or law enforcement office receives a suspicious package with white powder, and very concerning on the public health side, those samples get sent to the public health laboratory for confirmation testing. We have a budget of approximately $5 million general fund, a little bit of federal funds peppered in there, and 25 staff. Next, Mr. Chairman, slide 52, vital statistics. We've talked a lot about vital statistics already, so I'll be brief and just mention that in all of those, marriage, birth, death, certificates, et cetera, we have 10 staff located in Cheyenne, approximately $1.7 million general fund budget, and a peppering of other funds and federal funds. Also in public health, the next two slides, prevention and preparedness. Those of you who've been on JAC know our public health prevention programs run a gamut of both, suicide prevention, substance use prevention, also chronic disease prevention in terms of cancer, colorectal, breast, cervical, and skin cancers, and also tobacco prevention and control. This unit has about $4 million of general fund, $10 million in other funds, and $8.7 million in federal funds. Those other funds are typically tobacco settlement funds or other special revenue that comes into the state, and approximately 27 staff in this unit. And finally, on the preparedness side, this is really emergency preparedness that is directly or tangentially related to the healthcare system. The purpose is to build capacity across the state to respond to local emergencies like pandemics, natural disasters, terrorism, et cetera, on the healthcare preparedness side. This is almost all federal funds, about $14.9 million in federal funds. That includes hospital preparedness program and our Office of Emergency Medical Services with a total staff of 18. Okay, Mr. Chairman, we're nearing the end here. On the regulatory functions, again, I've talked about this slide 56, talked about this unit already, Office of Healthcare Licensing and Surveys. We regulate on the state and federal side various types of healthcare providers, both in terms of state life safety, construction, but also your federal conditions of participation in Medicare and Medicaid. A few fun facts there on that slide for you. And slide 57 just kind of breaks down the types of facilities that we license or certify and the count across the state of how many there are. And finally, Mr. Chairman, on the regulatory side, our Office of Emergency Medical Services, the purpose of this unit is to regulate and license EMS professionals and ambulance services. And we are statutorily directed to develop a comprehensive trauma and EMS system. So hot topic these days in the sustainability of rural and frontier EMS, something we look forward with our Labor Health Committee and with you all going into the next session to continue to discuss options to sustain what is a critical service when folks call 911, but extremely challenging. It's very high fixed cost and in some cases extremely low volume. To have that readiness available. So a lot of policy implications with EMS. But on the regulatory side, we have about 6 staff in this unit, $1.7 million general fund, and a peppering of federal funds and other funds. And with that, Mr. Chairman, thank you for the opportunity to do a 30,000 mile an hour overview of the department. We certainly stand ready for any questions as you get into the remainder of your agenda, and we'll be here all day to answer any questions you have as we go into the various budget units.
All right, thank you, Director. Very well done. You've got us not only back on schedule, but a little ahead. So we're going to take a break here. We'll come back at 10 a.m. and begin with what was scheduled to start at 10:15. And if any of you have any questions, I know I've got one or two. We'll catch you during the break.
Thank you.
And we are back. You know, this thing is not as thrilling as you might think. It carries a certain amount of gravity with it. So for the remainder of what we're going to do here is primarily focused on public comment. We're going to go down the agenda according to the units that are there and give a little brief description of that unit. If that unit administrator is available, give them an opportunity to add anything that may or may not have been covered, and then open it up for public comment. So at the beginning is Unit 100, first starting off with the director's office. I have to read the notes. It means I got to make them bigger. This administrative unit oversees, supports the 4 operating divisions, which we have had described to us capably earlier, and 5 state-owned healthcare facilities. This unit includes the Director's Unit for Policy Research, Evaluation, Fiscal Services, Office Administration, Public Administration Officer, and Office of the Privacy. What is the Office of the Privacy? Okay, I know you touched on that, the Office of the Privacy Security Contracts. You talked about HIPAA, that sort of thing. Could you? Thanks.
Mr. Chairman, happy to elaborate. So our Office of Privacy Security Contracts and Rules, a few components there. One oversees all aspects of privacy and security, both related to state requirements for the data that we oversee, and also through HIPAA, which is a federal law that organizations like ours are subject to. We have to meet certain standards of data privacy and data security. So for our Medicaid programs, our community mental health programs, developmental preschool programs, virtually everything with the exception of vital statistics services, which has its own state regulation and state standards for security. Everything is protected virtually by HIPAA. So we have essentially really one staff that's dedicated to all things HIPAA and privacy and security. In that office, I've formulated it recently in the past couple of years as our business administration office. So we have an administrator there, and we have 3 staff members who oversee the various components, including what I just mentioned with privacy and security. But also, as you can imagine, the Department of Health does a lot of procurement, and we need process and governance over contracts that each of which I sign on behalf of the agency. So in any given year, we probably do a couple of thousand different types of contracts. And so we have a staff member that oversees that process. In addition, just in terms of the nuts and bolts of getting a contract from procurement, RFP, all the way through signature with the vendor. We also have that same staff member also oversees our public records request process, which I'm proud of in the Department of Health. We manage those very timely within and below the standards that the state legislature has set for timeliness in terms of individuals who reach out. They get a very prompt acknowledgement, and we do quick analysis to determine if we can meet that request. And as you can imagine, there's often in those public records requests a lot of data pulls that need to happen, sometimes can be very voluminous. And so that staff member in the business office, Office of Privacy, Security, and Contracts, oversees that as well. Third, Mr. Chairman, Department of Health, as you can imagine, also has a lot of administrative rules. So when the legislature passes laws and we execute them, often you will give the department, through those statutes or session laws, rulemaking authority. And so we have a process in the Department of Health when any new rule is going to be promulgated, when any rule is going to be changed or amended or taken off the books entirely. Our business office, this Office of Privacy, Security, and Contracts, also oversees that and manages it both with internally with the Department of Health, with the necessary participation of the governor's office, since the governor is involved in approving new rules, the Secretary of State's office with the form and format and process that we go through with public comment on all of our rule promulgations, and then also with the legislature through LSO and legislative review of rule promulgations. So again, that's the broad overview of the Office of Privacy, Security, and Contracts.
Thank you, Director. Did you say that that was 2 FTEs in that?
In that unit, Mr. Chairman, we have an administrator and we have 3 additional FTE in that unit.
Have you considered looking at the amount of people you've got there and how much they accomplish? Have you considered the Department of Cloning?
Mr. Chairman, I don't think my staff in that unit are able to listen in today. I wish they would have, just for that comment. They do a lot with a little, and we keep that unit extremely busy.
All right. Do we have any public comment on the Director's office at this point? Anybody in the room? Seeing none, anybody online? All right, then, any other questions from the committee? We will move on. Director's Office, 130 vital statistics. I think that was fairly well covered in the overview that is there. Anything to add that you think we need to hear?
Mr. Chairman, no, not anything specific. I would just mention, again, this is I would call it a lean and mighty staff. I believe, if memory serves, we have 10 FTE in that unit for all of the various records. And I want to reiterate, this is in addition to being the custodian of record on these things as the state office, where I am the registrar. My administrator of that office is the deputy registrar per state law. And so we keep those records. We provide that information in annual reports and various reports to the legislature, and also, as necessary, use those data to inform public health practices. So we have some interfaces with public health and with Medicaid from vital records to, work smarter on behalf of the state. But the most important part of this office is really for the residents of Wyoming. It's consumer facing. So when folks, for various reasons, legal reasons, need their certificates, et cetera, we try to provide those timely, both in terms of in-person customer service in the Cheyenne office, but also over recent years through the development of our online portal where certificates can be requested, online, and we provide those directly. One issue that I'll mention over the years, as you can imagine, there's a lot of enterprising business out there with, if you were to Google, I need a birth certificate, right? Or I need a death certificate for one of my family members for whatever reason. There's a lot of enterprising companies that try to provide that service for a much higher fee, basically using our process and requesting it on behalf of that person. And we've really tried to instruct and do some search engine optimization online to point people directly to us, because requesting birth certificates, marriage certificates, divorce certificates, death certificates, much more efficient if you go directly to the Department of Health instead of a third party, and it's much cheaper to do it that way as well. So take this opportunity publicly to make that case for folks who might be listening.
Thank you. Do you have, I would assume you work closely with county coroners. Are there other county organizations so the question basically comes down to, are you doing all of the legwork, or are you basically just compiling data that's been submitted?
Mr. Chairman, good question. It's a little bit of both. So we work very directly with county coroners on especially with death records, and set per state statute. We kind of set the process and the governance of how those death records on coroner cases, which is not every death, but deaths with different types of circumstances, suspicious circumstances, et cetera. We set that process for the coroners and work hand in hand with them, both directly and through our online system with how they go through that process. Same thing with physicians and hospitals and healthcare facilities that might be doing the same types of, birth records, death records, physician reviews, et cetera. But then also, to your point, a large part of our work is we are just the custodian of the records. So we try to, have that local control and independence and strike that balance.
All right. I have been asked to note, if you're listening online and you have a comment for whatever unit we are on, I'd ask you to raise your hand so that we will know that you want to chime in on that. Any further questions from the committee? All right. Any comment from the room? Yes, sir. Please come forward and Give us your name and tell us what you want to hear.
Good
Welcome,
morning.
sir.
My name is Ross Schriffen, citizen in Casper. On the vital statistics, one area of concern is the abortion statistics. And as far as I know, there's no statute that indicates a review of those records to see if they're reporting correctly. So it's more of an honor system. So I would suggest maybe looking into making sure that that what's being reported is accurate. On the other areas, birth, marriages, those kinds of things, there's county records, but I'm not sure that there's any record or a inspection of those numbers.
Thank you, sir. It's good to see you again.
Okay.
Anyone else? Is there anyone online who would care to comment? Okay, seeing none, we'll move on into 400, which is 401 healthcare financing. This is where it gets fun, right? One question that I had asked earlier, and perhaps we'll throw this out for the public to hear the answer to. Obviously, predominantly, we're talking about Medicaid on state-run facilities. But my understanding is there are some Medicare that work into different places. If somebody could very briefly describe the scope of that.
Mr. Chairman, happy to do that. In Unit 0401 for our healthcare financing division, this is our administrative budget unit. So not state-run facilities here, although there's Medicaid funds that go to state-run facilities depending on the population. This budget unit, which in our most recent standard budget book for the current biennium is found on page 81 of that budget document. This is where all of our system costs, claims processing, eligibility systems, staffing, a variety of administrative categories are in here in the 0401 unit. Generally speaking, all administrative costs in Medicaid are 50% state funds, 50% federal funds. There are some exceptions to that, especially with technology. So recently, we've benefited from 90% federal match on the implementation of technology systems and 75% federal match per federal law on the operation and maintenance, so ongoing expenses of some of those systems. And you'll see that peppered throughout this budget unit, also our budget requests over the years, and potentially some impending budget requests for system enhancements, maintenance, et cetera, that the JAC will likely see in the upcoming session. You'll see some vastly different looks on the Medicaid requests where you typically think it's 50-50, but in some of these technology areas, you'll see 90-10 splits or 75-25 splits. Mr. Chairman, I'll hand it over to Mr. Springer, our Medicaid agent, if there's anything else he'd like to add in the administrative unit in Medicaid.
Certainly, Mr. Springer.
Chairman Pendergraph, I will note that in the administrative unit, we did note this earlier, but there's 600 series, so there's client travel. So if you see 600 series in 401, that's actually our reimbursement for non-emergency travel for people that need to travel, a long distance for end-stage renal disease or to go to care that's not in their town. We'll either give them mileage, we pay for Ronald McDonald House, those type of things. So that's an expense you might see there. That's not really what you would think of as traditional admin, but it is admin based on our federal definitions. So that's why it gets to live there. We also have the entire med donation program, the medication donation program that was mentioned earlier, lives within our admin here, the 401, because it is just staff and the supplies to run our pharmacy, but there's no benefits there. So it's not established as a separate unit. It's relatively small, less than $1 million, but I just will note that's inside this unit.
Mr. Chairman, if I may just reiterate something from this morning, because you'll see it in the unit and in the budget breakdown. on the 100 series. Again, generally speaking, we get 50% federal match on those salaries for the state positions, and in some cases, a higher match rate if they're working on certain technology systems or projects. But I want to reiterate that in healthcare financing and Medicaid in general, our staffing costs in what is essentially a $1.6 billion program are at or under 1% of the total budget. So it's relatively low. I want to do it publicly and commend Jesse and his team. Similar to what you mentioned about our Office of Privacy, Security and Contracts, do a lot with a little, and we're very sensitive to that in that we want to use state fixed cost staff as much as we can, because consultants and contracts are far more expensive, and I think they do a good job administering a very big program for the state with a minimal amount of state staffing.
Any other public comment from in the room? Yes, sir. We need to get you a chair out of no. No, we want people to feel welcome to come speak. Welcome back, sir.
Again, Ross Schriftman, citizen in Casper. It was mentioned earlier about people enrolled in Medicaid in more than one state. I think we do a great job here, but Dr. Oz, who's the administrator of Medicaid and Medicare services, presented to the U.S. Senate back in May that the federal government has discovered that $14 billion of taxpayer money has been spent on people that are enrolled in Medicaid in more than one state. In some states, they don't do a good job like we do here. So it's important. They're trying to make sure that people are only enrolled in Medicaid in one state. The other thing is back about 15, 20 years ago, there was an expansion of a program called Long-Term Care Partnership. It's a partnership between private insurance and government. At one point, there were only 4 states participating. And what that does is if somebody purchases a long-term care private insurance that can pay for everything from a home care, adult daycare, assisted living, memory care, full-blown nursing, if they purchase a policy under this partnership, it acts as a deduction for Medicaid. It doesn't help the people that are already on Medicaid, but what it does, if somebody can only afford a policy that only pays 3 years of benefit, they may never get to the point of needing to go on Medicaid, and they can keep every dollar that they have up to the amount that the policy pays. This was expanded. I'm an insurance agent. I do long-term care insurance. I served as the associate chair for long-term care on a national health insurance agency or a association. And I worked with members of Congress to expand that program. And the Wyoming legislature did pass enabling legislation about 10 years ago. So this is a program that's available. I've mentioned this to the insurance committee or the insurance department. And we need to let people know that this is available because it can slow the growth of our Medicaid spending for long-term care services. So I thank the committee, and I'd be glad to answer any questions.
Any questions from the committee?
Okay, and I'll give my seat back to the director. Oh,
No, we've got another chair.
seat, you're sitting next to me. Okay.
We've got another chair there, so
Okay.
it'd be a little bit more comfortable. Thank you for doing
Okay,
that.
thank you very much.
And thank you for the information. Other public comment? Do we have anybody online? All right.
Chairman Pendergraph, if I could address the 2-state enrollment that is required of all states by the Big Beautiful Bill, HR 1. And so the federal government is charged to build a better system for verifying that. They already have a system that we are using. We in, our most recent iteration, we had 1,200 people that showed up on that report, and then we started working that immediately to verify where are they actually a resident. Some of those people could be our resident, but we send them verification forms, we mail them, we call them, and we make sure they actually are a resident. And what they need to do is contact one of the states and verify their enrollment and tell the other states to disenroll. If they don't respond to us, we do actually disenroll them, and then they can reapply if they are actually a Wyoming resident.
Thank you, Mr. Springer. That does bring up another question. I've heard people comment about people they know who have substantial financial resources and yet somehow end up on Medicaid. Could you describe for us a little bit about administratively how we screen that? How intrusive is that? How does that work?
Mr. Chairman, if I may, I'll answer broadly and ask Jesse to weigh in as well. But Jesse's being modest when it comes to the system work that Medicaid has done in Wyoming over the past 8 years or so. I know Representative Sherwood, having served on the committee for a while, is aware of all the investments that we've requested and had lengthy discussions about why we're investing in these systems. That multi-state eligibility or enrollment, problem that Mr. Schriftman mentioned earlier, we're kind of a thought leader in Wyoming and implementation leader, thanks to the good work Jesse and his team have done, where implementation on some of those along those lines are not difficult for us because we've already established a lot of system interfaces with federal systems and can do that work really quickly. So I would imagine in the months and years to come, Wyoming will be rated very favorably on those types of quote unquote errors in the eligibility system or our operations just because of the work that's been going on. But I'll let Jesse speak to the question that you asked specifically, but wanted to make sure I acknowledge that we forget, and I know it's easy for you all as decision makers to forget year after year, okay, what did we do and why did we do it? But that big investment, mostly with federal funds that we made in system modernization has really paid dividends to the state in the efficiency of the system, the fraud, waste, and abuse components of it, and just making things work a little bit more effective and easier. But Jesse, please weigh in.
Springer.
Chairman Pendergraph, so not all the programs consider resources or assets. So a number of the programs, pregnant women, children, are based on income only. So that was part of the Affordable Care Act. So we don't actually look into assets at all. It's not allowable. It's not allowable by federal law. When we get into the more expensive programs, which is long-term care, so nursing home care, home and Q-based waiver, people can own a home up to $730,000, including surrounding land. They can own a primary vehicle that does not have limits on it. So there's no limit to the primary vehicle of that person or family. If they have a second vehicle, that is then counted at the cash value, current value. So that would count against them. And really then, there's a few exceptions, like, you can have a non-refundable funeral plot. And then everything else is limited to $2,000 currently. So $2,000 total value sets cash accounts in your bank account, anything you can withdraw from any other investment vehicle, the value of recreational vehicles, a trailer, really like any other asset that a person has. And this really catches people because $2,000 is not a lot of money. So people that are applying for that type of extra care hospice, they're limited to that $2,000 limit. And so what our team that lives in this unit does, which is our long-term care eligibility unit, it's about 30 people, they get those complex applications. They have to just make sure people qualify for income, but they also have to check their resources. And so that can take a lot. So we do self-reported, but they have to produce bank statements, other assets. We also have data matching with the Department of Labor and We have something called Acuity, which is also a data match on bank accounts. So we can see bank accounts and other assets that are held by those individuals. And we can verify what they're self-reporting to make sure they're below the thresholds that we allow. I know that's a common complaint that, hey, people have a lot of assets. And I think a lot of times what people are seeing in that situation might be that home or that vehicle allotment, because we don't have limits on either of those by federal law. Federal law sets a cap as of July on the home value up to $1 million. Wyoming has set its cap lower at $730,000 for that home. But the primary vehicle does not have a limit by state or federal law.
Mr. Chairman, if I can add, because I think the spirit of your question, not to put words in your mouth, is this is one of those delicate balances where, our asset limit in Medicaid long-term care at $2,000 is really a product of the late 1980s. So it's very low. So on the other side of that, we get quite a few constituent concerns, complaints, et cetera, legislators reaching out saying, hey, this is process is voluminous, and what you're looking into in terms of assets is so strict, right? We're just looking for some help for mom or dad or myself, and it's tough because that is a very low asset threshold, and I think it's relevant for the committee to know in long-term care and Medicaid, even with that, we still, in terms of nursing home coverage, Department of Health, Medicaid, we pay for 65 to 70% of all nursing home bed days in Wyoming. So even with those low asset standards, it just gives you a sense of how high the demand is for that, but also how costly those services are, where folks who may have saved several $100,000, $1 million, you can spend through that very, very quickly in a long-term care setting, and then we are the safety net for that. And so even with that pretty low asset threshold at $2,000, as Jesse mentioned, in kind of liquid assets, we're still the dominant payer in the long-term care market for nursing homes. So yeah, I think it's an interesting dynamic there. But Chairman Pendergraft, it's one of those things I know has come up at a few JAC meetings where what are the implications if we were to, as a state, raise that from $2,000 to $5,000 or to $10,000, and we've produced some of those analyses and answers on what it means for enrollment and monthly costs. But it's a tough policy decision as Wyoming ages demographically of, how should those services be provided and covered. And we're certainly at the table to help you guys craft what the future looks like there.
The kind of sticks in my memory that 730,000 for a house, 10 years ago, that seemed rather substantial. How often are those numbers reviewed? Is that legislative action?
Chairman Pendergraft, that would be mainly when we change these standards, we handle it through the budget, because changing the standard in some cases has some budgetary impact. So the only place that the current asset limit is established is in a 2003 budget footnote by the legislature. And then, we've reflected that in our rules, but there's no process for updating that. The home standard is not established by any legislative process. So, it could be reviewed and changed up to the new $1 million limit that the federal government has set. So some states had actually set no limit. And so recently in 2025, the federal government passed a limit as part of the big, beautiful bill to set a $1 million limit as the max. It didn't set a minimum, but it did set a max to say home value cannot go above that $1 million threshold. And in some communities, $1 million, in Wyoming and Teton County, it's very hard to find a home for that price. So, that's sort of thing that people face. But there are exclusions for this, if a spouse is staying resident in the house and one of the family members is going to long-term care, there is spousal exclusions and things like that.
Questions from the committee? Anything? Any public comment in the room? Anybody with their hands raised? So that's obviously a big one. We've just wiped out a big chunk of your budget right there. Moving on, Public Health Division. This administrative unit oversees and supports Public Health Division, including community health, the health readiness and response, and public health sciences sections. I've seen some advertising by Department of Health, and that I assume comes out of this department, or?
Mr. Chairman, so very similar to the previous unit we discussed in Medicaid, which was 0401. This is 501. So similar public health administrative unit. So a lot of those expenditures that you're talking about would come out of the specific unit budget, not this administrative budget. But essentially, this is very similar to the Medicaid unit we just discussed, the administrative components of the Public Health Division. So you'll, again, for the public who might be following along, in our most recent standard budget, full budget book, starts on page 155. This is about a $2.6 million unit with a split between general fund, federal funds, special revenue, tobacco settlement funds. 1.6 million of that budget supports staffing in the Public Health Division. So a lot of salaries for the Public Health Division come out of this administrative unit, as well as some other administrative expenses. But to your question, Chairman Pendergraft, things like public messaging would generally come out of the specific unit. So for example, if we're doing public messaging around immunizations, that would typically come out of the immunization or, the unit that would have the budget or the grant funding to support that, typically not out of the administrative unit.
Thank you. Regarding immunizations, for example, is there, who do we take advice from, like the CDC, or is there a kind of an official pecking order, or who decides what's recommended, I guess is kind of what I'm getting at.
Mr. Chairman, that's a good question. So yes, we work hand in hand with the Centers for Disease Control, CDC, in Public Health Division. I wouldn't say it's direct that, CDC or any other organization has direct control over what we can recommend or do in Wyoming. That's really vested in the Department of Health through our state health officer and through me as director. But we do interact quite a bit with the CDC. And as many of you know, there's been a lot of changes and new discussions at the federal level when it comes to the CDC. So we pay attention to those, whether they're new recommendations or structural things that might be changing in what's allowed or recommended and approved by another side of the federal house with the FDA. And so we take all of those recommendations or regulatory parameters and then decide what's best to recommend for Wyoming. But generally speaking, across, unless there's not an immediate threat to public health or safety that we need to act within Wyoming statute on, generally speaking, we in public health, we really encourage direct relationships between individuals and their healthcare provider. So you've probably seen a lot of that coming out of the Department of Health recently, that even amidst all of the changes, a lot of our recommendations are rooted in good patient to doctor, patient to healthcare provider relationships. But happy to elaborate, Mr. Chairman, if that didn't fully answer your question.
I think that's sufficient for now. Thank you. Do want to acknowledge fellow appropriator and fellow legislator from the beautiful town of Edgerton. I drove through your town the other day and I waved at you, but I didn't see you. But, okay. Bill Alamand, welcome. Is there any public comment within the room? Seeing none, anybody online? No hands raised. Again, if you're listening online and you want to weigh in on any one of these units, please raise your hand and we'll get to you. Thank you. We're going to jump ahead here to the behavioral health. This is something that has been, I won't say beaten to death, but we've had a number of discussions on this in a number of committees. And there may well be some public comment on this. The note here says this administrative unit oversees and supports the Behavioral Health Division and its community-based programs, including developmental preschools, community mental health, and substance abuse centers, and 2 state-operated facilities. Specify those facilities if you would. Anything you care to add to that?
Thank you, Mr. Chairman. Again, this is Unit 2501, another administrative unit for the Behavioral Health Division, largely supporting salaries for the division. So out of the total $6.6 million in this budget unit, 4.7 go to salaries. The vast majority of those salaries would be located at our Department of Health facilities. There's also some other elements within this unit. For example, the relatively new 24/7 988 suicide prevention lifeline that is operated out of this administrative unit as well, primarily because when that was created and the legislature was debating funding, there wasn't a standalone unit in the Behavioral Health Division for 988. Could there be? Yes, we can certainly have those discussions, but the budget unit here, for those interested, starts on page 234 of our standard budget and gives you the breakdown of those various costs.
Any other questions? No? Comments from within the room? Seeing none, anybody online? Quiet people today. Moving on, aging administration, 5,001.
Mr. Chairman, again, will sound like a broken record, administrative unit for the aging division, which we went over briefly this morning. That this unit starts on page 288 of our standard budget, again, largely supporting, personnel costs and support services costs for the aging division, which includes our community living section, which oversees our senior center programming, as well as 3 state facilities, the Veterans Home in Buffalo, the Pioneer Home in Thermopolis, and the Wyoming Retirement Center in Basin.
Now, during the earlier discussion, you talked about traveling nurses and the cost associated with that. That comes out of this section, or is that in the previous one we talked about with? Clear me up.
Mr. Chairman, the latter. So the large amount of those traveling staff costs or agency labor costs at the 3 aging facilities would come out of those specific facility units, which it looks like on the agenda we'll get to next.
Okay. It's all new to me, folks. Questions from the committee? No questions. Comments from within the room? No public comment? Anything online? Nothing online. Behavioral Health 2505.
Mr. Chairman, this is the Wyoming State Hospital. We discussed the state hospital at length this morning. So this, again, this unit supports funding largely in terms of staffing for the 24/7 state hospital and the 24/7 Wyoming Life Resource Center in Evanston and Lander, respectively. Relatively a large budget here, given that it's a 104-bed facility. Flip to the actual budget unit. Bear with me, Mr. Chairman. That begins on page 246 of our standard budget. And in terms of personnel cost, out of the total approximately $90 million standard budget on the biennium for the state hospital, approximately 67.8 million of that is in staffing. And as we discussed this morning, we have a large amount of vacant positions, primarily CNAs and nurses at the state hospital, that within that budget for personnel, when those positions are vacant, we take almost all of that funding, virtually all of that funding, to reserve for contract labor, as we talked about this morning, to try to keep as many beds open as we can for the jails, law enforcement, the court system through Title 25, hospital emergency departments around the state for these high acuity behavioral health patients. But it's a big challenge for us in the department. We've made a lot of strides at the state hospital thanks to our team and director of nursing in the last year and a half, where for entry-level CNAs, I think the last time I spoke with you all at JAC last December, we were sitting at over a 50% vacancy rate on entry-level CNAs. A year later, we're down to about 14% on that vacancy rate for entry-level CNAs. And we talked about a few of the mechanisms that I think are responsible for that this morning, with better educational support, low-cost or no-cost initiatives to build that pipeline within the state hospital. But also, I have to just commend our director of nursing and his team, because the partnership with our community colleges around the state, especially in the last 2 years, the amount of pavement they've hit to be at all of their graduations, recruiting events, hosting clinicals at the state hospital for those CNA or nursing students has been impressive, especially over the last 18 months or so, and I think results in a lot of that pipeline building at the state hospital. Having said that, entry-level nurses at the state hospital are still a huge issue. We're about 40% vacant on entry-level nursing positions. That's just a tough one in the current nursing market, with what folks can make either at other healthcare systems, potentially in the peripheral areas around Wyoming, Salt Lake, Front Range, et cetera. But also because the traveling nurse market has just exploded in recent years, where it can be very lucrative for folks to not take permanent positions and instead, work with these contract agencies. We're trying to break the back of that dynamic, that market, but it's proving challenging. So we're still we're struggling with entry-level nurses across all of our facilities. And I know that will likely be a discussion going into the next session of what some policy options are to correct that. Last thing I'll mention, Mr. Chairman, is that with the state hospital, it's really important to remember our customers are basically the clients that we serve there, both on the civil commitment and the criminal or forensic commitment. But indirectly, and you might even say directly, our customers are also the judges, the court system, the county attorneys, jail administrators, and sheriff's departments, who, when we are full or we don't have beds available because we're full, those clients are still there. They're waiting in local jails. They're waiting in hospital emergency departments. They're in the Title 25 system. So it's a tough system to manage, but one that is truly, I think, safety net in its core, because the clients are there, and we're working on various programs that we're optimistic and excited about, partnering with sheriffs and jails to provide, through the Department of Health, more treatment resources in the jail to help stabilize some of the very, very sick and acute and violent and self-harming clients that they have waiting for our care at the state hospital. Also, community diversion programs for your lower level misdemeanors, nonviolent crimes that could potentially be diverted out of the criminal justice system and into treatment that the Department of Health is already paying for or can pay for. So there's some exciting developments in various communities that I think can take hold over the coming months and years to work a little bit smarter with these systems and work together versus just pointing fingers at each other. And they're rightfully saying, State Hospital Johansson, you're taking too long to open up beds, and that's true. I mean, 4 to 6 months wait list on Title VII right now for the state hospital, about 2 months wait list on Title 25 at the state hospital. And we don't like that just as much as the sheriffs and the county attorneys and the judges don't like that. The solutions to those problems are complex, obviously involve some amount of resources, but also, as I mentioned this morning, there's other ways to manage this system. And I think some of the partnerships with the courts, with the sheriffs and law enforcement and jails are just in the last year or two are helping to stem that tide. We're on track this biennium to spend the least amount of Title 25 expenditures out of the Department of Health than we have in many years. And I think some of that's attributable to, the work that's being done in partnership with the department, the state hospital, and various community systems, in addition to the community reforms that you all have legislated recently to direct us with our Department of Health budget to really prioritize these clients with our state funding, criminal justice involved clients, acute psychiatric clients, DFS kids, the ones that slip through the cracks, as opposed to previous systems that were far more general access in their nature. So I think we're on the right track, but don't want to candy coat it. These are tough systems and tough impacts for your local communities and the stakeholders that I mentioned.
Any questions? Comments from within the room? Anybody online? We do have one online.
Yes. This
Welcome.
is Sam Burkett. I'm a resident of Laramie, Wyoming, and I rely heavily on what I think this issue of the AIDS and stuff like that with in terms of at the state hospitals is very important. Do you know how much would it be with the reimbursement rate and stuff would be? I'm just curious of do any of the at the Wyoming, the one in Evanston I'm talking about, is there any way that if they can get, is there reimbursement rates different from any other aid?
Thank you for the question, Director.
Thank you, Mr. Chairman. I think what I hear in the question in terms of aides or CNAs, certified nursing assistants, we, just for clarification, or maybe this is helpful, right now for an entry-level CNA at the state hospital, our starting wage is just over $17 an hour. For an entry-level nurse, it's between $31 and $33 an hour. And I think that's ongoing interaction we have with our Department of A&I, Administration and Information, on various flexibilities that they have given us, but we're really governed top line by the budget authorization and in what we can offer for those positions. So not necessarily a differing salary or reimbursement rate to the Ms. Burkett's question, but something that is kind of standardized across our facilities.
It's a Mr. Burkett. I'm sorry.
I'm sorry. Forgive me.
But yeah, I don't know what my voice isn't very pretty, but that's kind of, I get that a lot when I'm on the phone and stuff. But yeah, because I know the average rate for aides, just CNAs, is about, usually I think it's that's actually not much different from what the average one is. To be frank, I think it's 15 or 14 an hour for average, and then $2 an hour. But that is a big difference, however, in terms of state hospital. But I notice it's not just with the state hospital, but it's a problem all across the country, especially when you highlight the big beautiful bills that there's just going to be shortages all across the country. I'm concerned about the ability of hospitals just to decline care for those people that, like you mentioned earlier, I'm concerned particularly about hospital situations in Wheatland, And I was studying something about in, I think it was Lovell or Powell, that area. And I may be wrong on this, but that's what I heard. But and also I think but there was a hospital that just opened in Riverton, which I think is going to be good too. But like I said, these rural hospitals they're so vulnerable, and they're going to be widely impacted by this BBB. And that's one of the things that I wanted to go in here to, is because I wanted to listen about how the Department of Health was going to handle like cuts to basic health care. And I will give up my time.
Thank you, Mr. Burgett. I need to ask after your dog. I understand you have a beautiful dog. At least somebody here says so. Director, would you care to comment? Thank you.
Happy to briefly, Mr. Chairman, to the question about, potential cuts or scale backs from the Big Beautiful Bill or HR 1. As it pertains to Department of Health and Wyoming Medicaid, we don't anticipate many significant changes, if any, to reimbursement rates stemming from the Big Beautiful Bill. As we discussed earlier this morning, there are some scale backs in terms of federal funding, federal match rates for certain state Medicaid programs, primarily if they expanded Medicaid, certain managed care arrangements that Medicaid programs might have that we do not in Wyoming, and then a scale back on what we call provider taxes or supplemental payment programs. Those of you on the Appropriations Committee know that we have those programs here in Wyoming Medicaid, where we collect fees from hospitals, nursing homes, psychiatric residential treatment facilities, and then we match that collection with federal funds and redistribute that to increase cost coverage among those facilities. So it's a non-state general fund mechanism to increase cost coverage. And the Big Beautiful Bill in certain circumstances scaled that back, but Wyoming has managed those programs very conservatively, and we're not at any of the thresholds that were set by HR 1 or the Big Beautiful Bill. So we don't anticipate changes there. So hopefully that's helpful for context. Again, that does not take into account potential changes later this year and going into next year to the private insurance marketplace. That's something that the Department of Health does not oversee or fund, and we could see some changes there with the expiration of enhanced premium tax credits from the Big Beautiful Bill. But that's kind of to be determined with how Congress might act between now and December. But in terms of Department of Health and Wyoming Medicaid, we don't anticipate at the federal level from the bill significant cuts or scale backs there, primarily because of how we've operated the program over the last many years.
Thank you. Want to move on to the Life Resource Center. Has a couple of different units there. 2512 and 0472.
Mr. Chairman, the reason that there's multiple units here is because there's the unit in 2512 specific to the Life Resource Center operated out of the Behavioral Health Division. There's also a specific healthcare financing unit because many of these clients served at the Wyoming Life Resource Center are funded partially or primarily through Medicaid, and that's the reason you kind of have a split function in the units here. But Unit 2512, Wyoming Life Resource Center begins in the standard budget book on page 280, kind of some lengthy descriptions there. But similar to my overview of the state hospital, you'll see in this unit that out of the approximate $65.5 million biennially in the Life Resource Center facility budget, approximately $59 million of that is in personnel. And that stands to reason. The vast majority of costs in a 24/7 healthcare facility are going to be your staff, especially with your direct care labor. These are facilities that are open 24 hours a day. And so both in terms of direct care, nurses, CNAs, what we call direct service professionals in the DD world, or DSPs, but also security staff, maintenance staff, ground staff for that physical footprint. But Mr. Chairman, happy to answer any additional questions about the budget structure there.
Committee? All right. Anybody in the room? Is there anyone online care to comment on the Life Resource Center? Okay. Moving on to the Pioneer Home. 5040.
Mr. Chairman, Unit 5040 is the Pioneer Home. Bear with me while I get there. That begins, Mr. Chairman, in our standard budget book on page 312. And again, very similar. This is a smaller facility in Thermopolis. You can see out of our total authorized budget there of approximately $5.3 million on the biennium, around $4.7 million of that, again, is staffing with nurses, CNAs, dietary, housekeeping, support staff, et cetera. I did want to mention, Mr. Chairman, that this is for those who haven't been to the Pioneer Home, lovely little facility. They do a good job with taking care of the residents there. In recent years, we have incorporated more of a safety net mission at that facility in two different ways. One, did a lot of work to offset general fund costs at this facility by leveraging as much Medicaid and Medicare expenses as we could. Unlike the retirement center in Basin, which we'll get to next, this facility does not have an enterprise revenue account like the retirement center. So the budget can be a little bit opaque in terms of seeing that savings to the general fund budget, because that books straight back to the general fund when we collect revenue. That's not something that we keep or manage. Pros and cons to that model if we were to go in that direction, but wanted to make that clear. And secondly, over the past three and a half years or so, with Eric's help, who has helped oversee our aging facilities, we have tried to serve as many of our safety net clientele that need to leave the state hospital. They do not need to be locked in a psychiatric institution, both through community programs, as we talked about this morning, and prioritizing those clients in community programs, but also through our Department of Health facility continuum. And so we have been able to serve at the Pioneer Home, which is, I think, a good accomplishment, several state hospital discharges in recent years to have a more independent life, certainly lower cost, allows us to open beds at the state hospital, which is desperately needed for our courts and our jails. It's small in terms of volume, but I think meaningful in its impact to see folks who would have likely been for years and years at the state hospital be in a much more open, independent environment, and certainly at a lower cost. And that's the same for the retirement center as well, which we'll get to next on the skilled nursing side, that has also incorporated a lot of that safety net mission recently into its operations.
Committee. Pioneer Home questions. You both been there? Well, you should go to the state bathhouse while you're there. Anybody in the room? Anybody online? All right, before we get to the retirement center, I do want to stop in at the Veterans Home, near and dear to our hearts. You mentioned when we were talking earlier about we've got a brand new, beautiful facility there with 36 beds for some pretty serious care. And then we have some, you can come on up because I'm leading up to hopefully to ask you some comment. Leading up to the other building, which is basically 2 or 3 older buildings joined together, which means you have different levels and that. And Representative Connolly and I were both there to visit that not long ago and look in on that. And so Representative Connolly, if you have any comments or anything you'd like to say.
Thank you, Mr. Chairman. I do. That's one of the reasons I came down today is Our veterans home in Buffalo provides a tremendous service. And what we have is right now is we have a very, very old domicile area for our veterans. And I don't think we're doing justice to our veterans by not finally finding the funds to remodel and reconstruct the domicile area at this facility. When we toured, I've been up there a lot because it's in my town, but when you look at the old facility, the way the rooms are designed now, carpeting that needs to go, floors that are on a slant that should be, can't imagine how those fellas maneuver their wheelchairs and different things on those floors the way they are. And I would really respectfully request that the Appropriations Committee put that as a high priority. The price just continues to go up, and see if we cannot get that thing done in this session. Thank you.
Mr. Chairman,
Go ahead, sir.
if I may, to add to Representative Connolly's comments, so this has been a policy decision in front of the legislature the past 3 years, and also State Building Commission, et cetera. So the work has been done to not only apply for we've had our application in the federal and approved at the federal level for the 65% federal grant funds for the reconstruction for the past 3 years. The issue is on the appropriations side at the federal level of when the federal government will supply the funds to Wyoming basically at what could be a reimbursement. But the policy decision for the legislature for the past couple of years has been, should the state front load those what will be federal funds at some point in the future with state general funds to get started on the reconstruction project of the domiciliary in Buffalo. And it is a tough decision. I very much respect that there's, pressing needs now, and that uncertainty of, we don't know if it's 2 years from now we get the federal funds or 10 years from now. It's really frustrating at the federal level in the VA system. But to your point, Chairman Pendergraft, I believe both chambers this past session passed a version of that veterans home funding in their budgets, but ultimately, not having a supplemental budget rendered that, not funded. So you'll certainly see that again. I was at the State Building Commission several weeks ago, and they moved that project up on their priority list as a recommendation to the legislature. So as we get into December and next session, I'm sure it will be discussed heavily.
Thank you. Your memory is very similar to mine. We put that as a priority, and part of the argument there was the longer we delay, the less a percentage that federal funds actually become, and it just becomes more expensive. You're going to have to rebuild it. At some point, you just got to bite the bullet and do so. And so for my part, I did support that and will continue to do so. Anybody else comment from y'all? Any other public comment on the room, Pioneer Home? No, excuse me, Veterans Home. Anybody online? Okay. Now to the vaunted retirement center.
And Mr. Chairman, forgive me for overlooking the Veterans Home. I'm trying to keep up with the units on the page, but
You're not the first to have overlooked.
I overlooked it in my comments. Moving on to the Retirement Center, Unit 5060, begins in our budget book on page 322. This is our skilled nursing facility in Basin, Wyoming. You can see on the budget breakdown that out of our total authorized budget of $13.7 million. 12 million of that is budgeted for personnel costs. Again, very similar across all of our facilities that you see the vast majority of budget and expenditures there on the salary side. I will reiterate, Mr. Chairman, that at the retirement center, which is a bit unique from our other facilities, we do operate the retirement center with an enterprise revenue account that renders it effectively state general fund neutral. And so through our collections from Medicaid, Medicare, private pay, we operate that facility in a quote unquote break even manner, with the exception of facility depreciation. And because we serve Medicaid clients, there is a Department of Health expenditure just out of a different unit, but it's matched 50-50 with the, with federal funds. So in terms of the aging division retirement center unit in and of itself, it is basically general fund neutral. And the final thing I'll mention, as we discussed this morning on the personnel side, we really struggle at the retirement center with recruiting our direct care labor, especially nurses and CNAs, and are heavily reliant at this facility on very expensive contract labor. Mr. McVicker, to my right, and I are working on, provisions to, amend and change those staffing contracts, because it's just not sustainable going forward. And we're not on a good trajectory with that enterprise account from the revenue we collect there to be sustainable for the long term. Those are difficult decisions on what it would potentially mean to right-size the facility, but also to, as I mentioned before, alter those contracts where we potentially add restrictions in there on how long we rely on contract labor, and what restrictions we put on, how long we will have a contracted nurse on the floor. But again, difficult discussions, because your retirement center in Basin does a really good job taking high acuity clients that are involuntarily discharged from other nursing homes, primarily because of their behaviors. So advanced dementia patients with mental health or psychotic issues. We do serve through 2 locked units at that facility, that type of clientele, and including over the years, several state hospital discharges. So there's a safety net aspect to that facility that, again, I've hesitated on making major changes to the bed capacity of that facility. But on the other side of that coin is the price tag of contract labor that, again, I think we'll have fruitful discussions in the upcoming budget hearings and sessions on how we could stem that tide, both in terms of internal efforts from the Department of Health and, recruiting in-state, Wyoming-based state staff that are far cheaper than these $70 to $80 an hour contract nurses. And even on the CNA side, right now, a CNA under contract costs the department about $50 an hour, where our entry-level CNA wage for these safety net facilities is just over $17 an hour. So there's a big disparity there, an opportunity long-term to really offset some significant general fund cost. But it's tricky because it comes with some investment on the front end to essentially stem that tide. But with that, happy to answer any questions about the retirement center.
Senator Larson.
Yes, Mr. Chairman, thank you. So do you give any incentive for traveling like from Cody or Powell to come down there? Is there, I guess that's my question.
Mr. Chairman, Senator Larson, it's a great question. Yes and no. So we got authorization a couple of years ago to offer $2,000 sign-on bonuses to staff that will come to Department of Health facilities. We've used that. I wouldn't say it has been a game changer in terms of recruitment. You do have sign-on bonuses at other facilities that are north of $10,000. So, I don't want it to be this arms race where the state and the industry are constantly trying to one-up each other. And I think what it comes down to is, we're trying at our Department of Health facilities. It's clear at the state hospital. It's clear at the Life Resource Center. But with these others, what does it mean to be a Department of Health or safety net facility, and what types of clientele or patients should we serve to help other systems? So you really do have to, I think, as a staff member, have that motivation to serve some of the toughest of the tough. But in terms of specific incentives for particular regions, no, not so much outside of the bonus structure for sign-on that we've offered. And as I mentioned this morning, We do offer educational leave and some tuition reimbursement for advancement, but still the struggle remains.
I have a preventive maintenance background. And I tend to look that way when I think about some of these facilities and lower levels of care, when you think about the senior centers and those other things. And I just think the monies that we spend on lower level care to make them go as far as they can, rather than just, we've got no place to put them, so we're going to put them into the intensive forms. It just seems prudent to me, and that's one direction, if I can tip my hand a little bit, that I'm looking at is, we used to call it tripping over dollars to save dimes. That's something that I would kind of put into your head, that are we doing the best we can at these lower, less expensive forms of care across the board? Or are we neglecting them because we're so desperate to fund the big ones? Just care to comment?
Mr. Chairman, you're absolutely right that our safety net facilities in the Department of Health are by their nature reactive, right? We are seeing folks that slip through the cracks of society, that get committed to the state hospital, that need to be served at the Life Resource Center, et cetera. And I think you're absolutely right that, community programs before you reach that need or level of care are essential to, not move towards dramatic institutionalization again, that's the only option that we have. To that end, just reiterate something I mentioned this morning that is relatively new but growing. The pretty comprehensive reform we implemented to the way we pay and who we pay for when it comes to community mental health and behavioral health services are absolutely directed at these types of populations. And both front end and back end impacts, I think, are possible there. With prioritizing this population in community programs as opposed to relying on very intensive and expensive institutions. In addition, I think you'll see that kind of hopefully see that kind of partnership, and hopefully would be echoed by our partners in law enforcement, in the courts, et cetera, that in recent years, that collaboration has absolutely grown to have lower cost, but also, for lack of a better term, more humane programming at the community level, so that it's not just everybody with an intensive need has to be dumped into the legal system and ultimately an institutional system. And that holds true for Department of Health, for DFS populations, Department of Corrections populations. I really do sense, Mr. Chairman, we're on the right track. There's a lot of work to do, but those partnerships are absolutely growing. But your point's very well taken that it's one thing to staff up and to have these expenses for these institutions, but back in, I believe it was the 60s and 70s, our former administrator of the state hospital, we actually found this in a time capsule vault that was put into the bricks of the state hospital when we did the construction project, found these materials. His name was Dr. Karn. And he had a lot of interesting comments that his goal was to basically eliminate the state hospital as a need, because we need to have front end and back end continuum of, behavioral health and these types of healthcare services. Obviously, that's a bit of an exaggeration. The legal system demands that we have a state psychiatric institution for these clients. But I think the point, the spirit of that is the state hospital does not function properly unless you have this front end and back end continuum that can not only prevent the need to go to those institutions, but if that's required on the back end, be able to have successful discharges and community supports there. So long-winded answer, I apologize, but I'm passionate about that issue. And again, I think the state's moving in the right direction with the investments it's made recently.
Thank you for that. Any comments from the room? Anybody online? All right, at the agenda, now we get to the really fun stuff. We are into healthcare financing. And the first item up is 420, which is Children's Health Insurance Program, SCHIP. Could you give us a brief view of the scope of that, how that works?
And Mr. Chairman, just for the next several agenda items here, if it's okay with you and the subcommittee, I'll defer to Mr. Springer, our head of the healthcare financing and Medicaid. Happy to provide color commentary if you'd like, but he's well equipped to give you brief overviews and answer questions.
You may, sir, rest your voice.
Chairman Pendergraph, Unit 420 is our CHIP program. So CHIP is an extension of eligibility beyond the Medicaid eligibility. So there's a couple standards, but basically between roughly 150% of the poverty level to 200% of the poverty level, this program supplements eligibility so children can have health insurance. Our model since October 2021 has been M-CHIP model. So basically Medicaid and CHIP look identical at this point. So they're on the same benefit package. It's very easy for us to run. And we use all the same technology systems. So that was implemented as a budget reduction, which we've done a number of studies that are available through the director's website, but we estimate saved 25 to 30%, mostly from reduction of administration. And there's something called medical loss ratio, but those are some of the changes that came about due to that change. So this serves currently about between 3,500 and 4,500 children. We almost got up to 5,000, but it started dropping. So we were actually at our highest enrollment ever, but it started dropping in the recent months. So it's back down to about 4,500 children. So this is one where we're seeing children start to leave Medicaid because the economy's good, the family incomes are increasing. And so where they're ending up is on the CHIP program, which is, I think, a good thing overall for society. But, it's just where is the money being spent out of each unit? We are not down as far on our Medicaid child enrollment. So what we're looking at is, this unit is currently funded about 3,500 children. We are able to transfer money between the Medicaid child unit and this unit. But that's what you'll see over time is that this unit is starting to grow a little bit as children leave Medicaid.
Thank you. Questions from the committee? Comments from the room, anybody? And anybody online? Okay.
Chairman Pendergraph, I will note this program is different than Medicaid. Medicaid base federal match rate is 50%. This program is 65%. So you might think 50-50, 2/3 federal on this program. So this one, the match rate is more generous. So it does reduce the state general fund to get to coverage. The costs per child are relatively close to the same as a Medicaid child. Medicaid is a little bit more expensive because we cover foster care children and some tougher populations, but they're very similar.
Anybody else? Anything? Unit 461, Children's Services. I'm going to scroll down. Medicaid provides basic health insurance coverage to approximately 51,000 eligible low-income children. The Wyoming Department of Health uses these funds to provide the basic health care services that are mandated under the Social Security Act for all Medicaid beneficiaries, as well as those mandatory under the early and periodic screen diagnosis treatment. Just as a curiosity, looking back in 23 and 24, there were some other funds. 25 and 26, there are other funds. What changed from prior to that? From 2017 on the thing that I'm looking at until 2022, it was all general funds, federal funds. Am I looking at the wrong thing?
Mr. Chairman, I'll let Jesse clarify if I'm wrong. I believe the general financing is the same over those years, but during the pandemic, we had enhanced federal match. That could have been booked as other funds. Jesse, I'm not sure if you know the root of that change.
Oh, I wish it was that simple. Chairman Pendergraft, so when you see here this school foundation program and the education non-statutory, we have a program that is authorized by the legislature for school-based services in the schools, Medicaid school-based services. It's optional participation for school districts. As of today, we have no districts participating. We did have some districts that explored it, participated with us. We had one that was billing and having some success with the program. They had some staffing changes, some turnover, and then that district left. So as of today, we have no districts participating in the school-based services program. So that would be where we could reimburse districts for some of their staffing costs for special education primarily. So those would be skilled medical professionals that are working in the school, school psychologists, other staff members like that. And this has been addressed kind of at length at the Education Committee. They have had a number of hearings on school-based services. They have not sponsored any legislation to make it mandatory. So that's kind of been the discussion. So with optional participation, there's just not the interest there. The funding model for that piece, I'm sorry that this is such a long answer. The funding model for that piece is that the funding would go to the district, but then go back into the trust's accounts that fund education. So the districts don't actually receive any extra funding. It was just helping to fund the 100% special education model. Other than that, the rest of this unit is essentially 50% federal funds, 50% state funds. We did have an enhanced match rate of federal funds for a short time during the public health emergency, but that has expired.
Committee, questions, comments? Anybody in the room? Anybody online? Moving on then, Unit 462. Out-of-home placements. Wyoming Department of Health uses these funds to pay for the medical services for approximately 3,500 children who are in custody of DFS. Comment?
Chairman Pendergraft, so this unit, and you might see that it has increased because we've changed basically where expenses were falling with our new technology system in 2021. So this unit is paying for the care of foster care children that are in the custody of DFS plus subsidized adoptions. It's also paying for out-of-home placements in psychiatric residential treatment facilities. And it is paying for the children's mental health waiver. So the children's mental health waiver is a relatively small waiver at this point, serves about 50 to 75 children that don't otherwise qualify for Medicaid but have high behavioral health needs. And then we have a program that's available to everyone on Medicaid if they meet high acuity of mental health, which is called the Children's Mental Health Wraparound, which provides support to the child and to the family to try to keep them in the community. So it's one of the programs we have basically to try to either get people back home by both counseling the family and the child and working on a number of things. And it's supplemental to other mental health treatment. Or it's helping people return back to the community. So we're actually discharging from psychiatric residential treatment facilities into this program and really trying to stabilize the children in the community. So these programs have been created in the last 10-ish years to be an alternative to that institutional care. They are a lot less expensive per month than sending a child to a psychiatric residential treatment facility.
Committee? Questions, comments? Anybody in the room? Yes, come on up. You guys can take a back seat for a minute. Please come on up and fill the chairs, introduce yourself, and tell us what it is that we need to hear. Let's start with you, sir.
Morning, Mr. Chairman, members of the committee. I hope you don't mind a quick break. My name is Clark Fairbanks. I'm the director of the Wyoming Youth Service Association. We're a nonprofit youth service agency that's members of 17 nonprofits across Wyoming who serve Wyoming's children. And specifically as it relates to the budget of 0462 out-of-home placements. Just wanted to talk a little bit about how that operates within Wyoming. And also with me are two of the members of the Wyoming Youth Service Association. I'll let them introduce themselves real quick.
Good morning, Mr. Chairman. Members of the committee, my name is Rhonda Meyer. I'm the executive director for St. Joseph Children's Home, which is a psychiatric residential treatment facility in Torrington, Wyoming.
Good morning, Chairman and Committee. I am Stacy Nelson. I'm the Executive Director of the Children's Advocacy Project here in Casper. We actually provide forensic interviews and therapy and some prevention programs for kids that are going through abusive situations.
Could I ask you to pull the mic just a little bit closer?
Sure.
Some of us are a little older.
Would you like me to repeat it?
Please.
Okay,
Thank you.
I'm Stacy Nelson, the Executive Director of the Children's Advocacy Project in Casper. We provide forensic interviews, therapy, community education, some prevention aspects for kids going through abusive situations. So, and we are part of the Wyoming Youth Service Association as well.
We provided a handout for you today that will help our presentation be brief. But I just want to highlight and provide a little bit of crosswalk for you on the budget and then what it means for impact for our communities and children and families. We are really the preventative maintenance side of working with children and families across Wyoming. If you look at preventative services, our 17 member agencies served 4,141 children last year. That included after-school programs, mentorship programs, parent education, community engagement. And those are kids who've been identified as struggling. Our local law enforcement, our schools, our counseling agencies often referring children and families to those services early on to get support and education that they need. And then intervention services served 5,547 children. And that's a little bit higher level of service, outpatient counseling, day treatment programming, wraparound services, and forensic interviewing. Again, working with those critical partners in our communities. The crisis shelters across Wyoming served 1,192 children. Average age in those crisis shelters is 14 years of age. So again, early interventions, working with communities in crisis, parents and families that are in crisis. 96% of those children return home after a very short stay at the crisis shelter and then continuing to support them. The group homes across the state serve 225 children. Those group homes, often we're seeing a little bit older children. The average age is 15. And there's they're often children who are court ordered. So district court judges are court ordering those children into the state's custody. And those children then are placed at group homes, and I'll talk about RTCs and psychiatric residential treatment and BOCES as we go through this continuum of care. Residential treatment, again, we comprise the nonprofit youth service residential treatment centers. 93% of those kids are returning home following that treatment. And then psychiatric residential treatment, and I'll let Rhonda talk a little bit about that level of service.
Thank you. Certainly, it is always our association's desire that children and families be treated at the least restrictive environment and as close to home as possible. When that isn't possible and they need a higher level of care, there are 2 psychiatric residential treatment facilities in the state of Wyoming, and only 2. St. Joseph's is one of them. We are the only facility that treats children ages 6 to 17. The other facility in the state treats only girls ages 10 and up. We treat both boys and girls. All of the current kids in our care are from the state of Wyoming. We currently are licensed for 62 beds. Our current staffing capacity is 45. We have been challenged similarly as the director has in operating state facilities with recruiting and retaining the staff, and particularly the clinical staff we need to be able to treat children and families. 85% of the children we serve from Wyoming are Wyoming Medicaid eligible children. 93% of the children that we have served go on to be successful and to a lower level of care back into their home communities, often with the support of my colleagues and their programs across the state to make sure that they continue to get the support that they need. So I'll stand for questions after you're finished.
Ms. Mayor, I had a question. I assume with a name like St. Joseph's that there's a spiritual aspect to that. Is there a chaplaincy there? Is there some sort of spiritual guidance offered in addition to the other services there?
Absolutely. That is, Chairman, thank you for the question. We absolutely believe it's important to tend to the whole child, both mind, body, and spiritually. We do have a full-time youth minister on staff who also happens to be a licensed clinical clinician. The services we provide are completely voluntary. Families and children must agree to and consent to participate. They're never forced to participate, but it is offered as an avenue for care and treatment. So.
Thank you for that. And kind of the same question regarding the crisis shelters, group homes. If you could tell us, Mr. Fairbanks, do any of them have some sort of a chaplaincy or plugged in that way?
Mr. Chairman, members of the committee, I'll speak about my personal experience. 30 years of working in Wyoming in Gillette as a director of youth emergency services. And then I was also almost 6 years the superintendent at the Wyoming Girls School. So to answer that question, I believe all of them have a spiritual component. It's different in the sense that in my experience at the Yes House, we embraced the faith community in our community. We engaged families and supported families of staying involved in their supports. The religious community, a critical role in that. So it may be less of an agency provided, but really as an agency supporting the importance of those community supports and keeping children and families in their communities connected. And that's a critical component of that.
So then these agencies are not in any way trying to shield the kids or block that aspect out. They're okay. I am a pastor, have been for many years, and that's always important to me. I see people as spiritual beings. And if we neglect that, we're, in my view, just throwing money down the hole. You look like you need to comment, sir. Go ahead.
Well, I was just going to share with you examples of not just supporting that, but also having services. We allowed faith community to come in and provide services. And again, it was voluntary for kids and parents to participate. So while we didn't have a chapel, as an example, at the girls' school or at the Yes House, we still provided those services on site to make that easy for kids to participate and families to stay involved. And I just give that as an example. Also, on the back side of this presentation, I just wanted to highlight a little bit. We talked a little bit about who we are as service providers, but I want you to also understand a little bit about the kids that are being served with the state funding, with our level of care, and that state funding is only a portion of what supports those nonprofit agencies. It's also local community support, foundation supports. Of the children we served last year, 80% of them experienced some form of abuse. 34% of that was sexual abuse. So you can see I want you to think about that 14-year-old boy or girl that comes into the crisis shelter in crisis. That child and that family never intended or thought that they would need the services of our member agencies. And they may crosswalk emergency service at 2:00 on Saturday night, came into the crisis shelter. They engaged a child advocacy center for a forensic interview. Law enforcement may have brought them in, or the parents brought them in. They have assessments. We work closely with that family. That child needs treatment for the trauma that they experienced, and that could be at any level, the group home, residential treatment, or psychiatric facility. One of the other components of that, 47% of the children had a parent that was incarcerated. So we look at some of the conflicts that are going on, and again, our member agencies are really focused on strengthening the family, working with those community providers, local drug courts, getting parents clean and sober, which is a driving factor for incarceration, so they can be a better parent. And that's really the network of work that we do as a member agencies. And we thought it was important for you to understand the critical nature as we look at numbers and budget, what the services are that are being provided.
Well, thank you for bringing that. I'm looking at the success rates, basically returning home or to a better environment, 96%, 87%, 93%, 95%, which leads me to how does recidivism figure into that? Do you put them back in there for a while and then they're back into the system again? How's that work?
Mr. Chairman, I'll jump into that again from my experience, and I'll have other members talk about that. Recidivism is a factor. I think the lower the level of care, the more likely you are to have recidivism. And I often saw that as a director in Gillette of the crisis shelter. A 4-day stay at that crisis shelter didn't fix everything that needed to be done. And the child and family coming back maybe a time or two again for that shelter services was important for them. And we tracked, I've been retired from that for a few years, so I don't have the actual numbers of statistics on recidivism, but we tracked that. We did that at the Wyoming Girls School as well. As you go higher into the levels of care, from my experience, you have less recidivism, at least at that higher level of care. So a child who was in residential treatment, returned back home, may have a short crisis shelter statement or placement following that, or step down, but less likely to go to the highest level of care again. And so from my time experience, when I was at the Yes House, the crisis shelter, we had about a 40% recidivism rate. And I saw that as a real positive, just as an example, because the children and the families viewed it as helpful and supportive. And at that preventative level, it was very appropriate. Hope that anybody want to add to that.
Thank you, Chairman and committee members. I agree with Clark. I just want to reiterate that I've worked in the various continuum of care. I did the work in crisis, residential, and group home for 22 years before I moved to the position that I'm in currently. And I think that is an important piece of when they are coming into the crisis center. It's not necessarily a negative thing. It's because they are reaching out. It's kind of like general maintenance. Like sometimes they just need some extra support, and they know we are in the various communities to obtain that support. At the Children's Advocacy Project, I would say CAP, we do the same thing. We have therapists that will work with the children and families for an indefinite amount of time. Sometimes then it will stop, and then maybe 6 months later, a child will start having some issues, some behavior problems. They may have been triggered by something, a trial coming up because those cases are mostly involving criminal cases. Sometimes it's their offender is getting out of prison or something like that. And so they just need some support so that they don't start spiraling. ACEs and trauma have been discussed for a long time with how these affect the kids. And we all, as WISA and all the providers, we just want to make sure that those kids are being treated and helped so that they don't have those continued issues later in life and can be, happier and positive members of society as they grow older.
Thank you. Any questions from you guys? You happy? Okay. All right. Thank you for your comment.
Thank you.
Anybody else in the room? Mr. Schwartz. Former legislator extraordinaire. Welcome.
Thank you, Mr. Chairman. I'm not quite sure how extraordinaire, but my name is Andy Schwartz. I am the lobbyist for WISA. I did not want to come up here with the providers because I think they're the ones, they're so good. What can I say? But I'm also the lobbyist for the town of Jackson, and I served 12 years as a county commissioner there. And I just wanted to emphasize how important the services they provide for the children contribute to the overall health of the community. And it's not just a financial contribution that comes from the town of Jackson, which is pretty substantial, but it's the way they work with the providers in the community to ensure that these children have the opportunity to succeed and come back into the community and ultimately if possible, in Jackson, it's a little tough, stay in the community and work in the community and grow families there. And I just wanted to make sure you recognized that relationship. And I stand for any questions.
Are there any? All right, thank you.
Thank you.
Anyone else in the room? How about online? I understood that we had somebody from DFS, and I just wanted to make sure that they did not want to comment. I don't want to miss anybody.
Mr. Chairman, no, there's no one who's raised their hands at this time.
Thank you. Page 2. $431 Medicare Part D clawback. And for my benefit, I would imagine Mr. Springer might be the best one to do this. Kind of just a really brief overview of how Medicare, how Medicare works, parts A, B, D, ZYX, whatever. If you could give us that, that would be helpful. Thank you.
Sure. So I'll do the Medicare kind of overview first. So Wyoming doesn't operate the Medicare program. That's operated nationally. There's Medicare Part A, which covers hospital benefits, institutional type care. Medicare Part B that covers physician type care. So that would be kind of that type of care. Some people have Medicare Part C, which is a combo of A and B together, sometimes combined with Medicare Part D. Medicare Part D is your pharmacy plan, and if you're on Medicare. And so that would be a standalone plan. And so Medicare is working these all as kind of separate plans. So you have A, B, D. If you're on traditional Medicare, your administrator in Wyoming would be Noridian. You might get things if you're on Medicare from Noridian. They process those claims. If people choose to, they can be on a Medicare Advantage plan. As far as I know, the Medicare Advantage plans in Wyoming as of this year, for the upcoming plan year for 2026 would be Blue Cross Blue Shield of Wyoming and United Healthcare. It operates under a different brand name in Wyoming for that United Healthcare plan. But I think those are the two plans that I'm aware of that are offered.
And Mr. Chairman, just very briefly, because I think it's helpful for the public that might be listening. As Jesse mentioned, Medicare is traditionally for those 65 and older or certain individuals with disabilities, but it is a purely federal program. The interactions that we have as Department of Health and primarily Wyoming Medicaid are with individuals who might be part of both programs. So we typically call those dual eligibles, meaning you're eligible for Medicare, but also meet certain categorical criteria in specific programs for Medicaid. But I just want to be clear that while we in the Department of Health fully operate and oversee the Medicaid program, we do not operate or control or regulate the Medicare program. And I know I'm sounding a little bit pedantic, but we even get confused, working in this industry. And I know it's easy in the legislature when you have all these issues coming at you of just the difference between Medicare and Medicaid. So there's a few units that you'll see kind of in succession here that deal with these sort of dual eligible clients that when we do interact on the Medicaid program with the federal Medicare program.
Okay, do want to hear more about that. You mentioned the healthcare licensing, the survey groups. Do they not, as a state agency, act as an agent for the federal Medicare to make sure that the qualifications are being met at facilities?
Mr. Chairman, yes, it's a good clarification. While that office that is in my office, Healthcare Licensing and Survey, does not operate Medicare, it does, as we discussed earlier this morning, enforce compliance and conditions of participation with Medicare. So certain things with nursing homes, hospitals, other types of providers, that if that provider is enrolled in and serving Medicare clientele, must meet certain standards that our office in Licensing and Survey would absolutely enforce and take compliance actions on, but it's not an operational oversight.
Thank you for the clarity. This has a really good button on it. Apparently chairman talked a lot. Anything more to add? Proceed.
Sure. So for Unit 431, Medicare Part D clawback. So in 2003, this program was created because there was federal legislation at that time that shifted the cost of prescription drugs from the Medicaid program to the Medicare program. So Medicare then started offering a prescription drug benefit, and individuals that were eligible for both programs started getting their pharmacy coverage from Medicare. And the way that the federal government funded that was to claw back from the states our portion. So that's what this is. So it's a mandatory program. We really don't have much options here. We manage this mainly by the number of people enrolled, and we're assigned a monthly fee per person for that coverage, and we're sent an invoice and we pay the invoice. So this is 100% general funds because we are paying our share of a federal cost for the people that are on Medicaid. This one has been growing relatively rapidly. And I think when we go through these Medicare costs, I'll note this is one that grows both because the allocation grows, the per person cost grows, and our Medicare enrollment has growing as we have an aging population. More people are on Medicare and Medicaid at the same time. So we're paying this share of the costs. So this is something we get an allocation. They give us a letter and they tell us due to high drug costs, the allocation is going to grow by this % this year per person. And then we look at our enrollment and then we're able to estimate what that cost is going to be.
Mini question? All right. Welcome.
Thank you. Are these payments made monthly, or is it, can the state sort of like track that and then pay that at the end of the year? And then if so, are we earning interest off that?
Chairman Pendergraph, Representative Sherwood, we pay it monthly. We don't get interest or anything like that. They send us basically an allocation letter to say, last month, this is how many people were enrolled in Medicare that were also Medicaid enrollees. We do a data match with them, and they send us a bill for those individuals.
And Mr. Chairman, if I can mention here, since all of you serve on JAC, and you'll know from previous budget hearings and sessions that it's frustrating when we bring the Medicare type request, including this one with Part D clawback, because we have very little control. It's a bill that we get from the federal government. With our demographics aging population, as Jesse mentioned, we have forecasted some growth. We bring you those requests, and it's one of those areas where there's some sticker shock there on the amount of those requests. And if you don't fund it, we hate to be the ones putting you in hostage situation, but they'll just take the money from our federal allocation. So there really is very little control that we have over this. So just queuing you up for December and going into the session, you'll likely see some of those requests, and happy to get into the weeds when those discussions come up.
Very briefly, just looking at the numbers, 21, 22, almost 37 million, and it drops to 30, and now it's almost 40. Is there
Chairman Pendergraph, the drop is mainly because of that match rate enhancement during the public health emergency. So when they increased our match rate, it actually applied to this program, and the way they calculated it, even though there is no federal money, the bill went down. So they kind of calculated that on the front end to say, okay, well, the state's share should be this. They used the match rate, and we got a smaller bill during that time period. There were still just as many people. We just got a lower bill during that time, and it was the same cost, really. It was just the match rate.
Yes, Senator.
Yes, Mr. Chairman, thank you. So you're just estimating what it's going to be in the next 2 years, I guess. So you're just going to say, yeah, add 10% or whatever.
Chairman Pendergraph, Senator Larson, they do send us a letter each November or December telling us what the next year will be. And then in some cases, there's an organization called MacPac that does estimated 2 years in the future. So they do some estimating of what the pharmacy trend is on expenditures. So if that pharmacy trend ever went down, then we could have a lower allocation. Or if our Medicare, Medicaid enrollment ever went down, which is possible. And then, after this wave of people in 2030, it is possible that it could eventually go down.
The last of the boomers. Any other questions from the committee? Inside the room and online. All right, moving on. Dual eligible excluded drugs. That sounds exciting. 432.
Chairman Pendergraph, this is actually a relatively simple program, and it's actually been shrinking over time because there's fewer things that are excluded from the Part D coverage. So these are over-the-counter drugs that are not covered by Medicare, but as Medicare actually has expanded its Part D coverage, you can see this is a relatively small unit of $77,000 every 2 years. So we're spending less than $35,000. $40,000 a year or less on these type of drugs. So these would be things that are not covered by Medicare that we were continuing to cover. So it's relatively small. So it basically, if someone needs aspirin off the shelf, Tylenol off the shelf, that is a covered Medicaid benefit. So they would go through this type of program if they're on Medicare.
Okay. Ivermectin. You don't have to answer.
Ivermectin would be prescription and would go through the normal.
You don't have to answer. Any trying to liven it up. Any other comments or questions from the committee? In the room and online. All right, moving on. 433 Medicare crossovers. Yes, sir.
Chairman Pendergraph, Medicare crossovers. So individuals that are both on Medicare and on Medicaid, Medicare is actually their primary source of medical insurance. And so what the state is doing is paying their premium through Medicaid. And then if they have any cost sharing, we pay that cost sharing on their behalf. So that's what Medicare crossovers does. We're paying that cost sharing deductible portion. And once that amount is paid, then Medicare is paying 100% of the cost. So what you're seeing here is just that portion of the cost sharing. We do have a cost sharing methodology that was implemented, I believe, in 2014 that we pay the lesser of. So if what Medicare has already paid is more than what Medicaid would pay as a single payer, we don't pay anything. And that amount is not recoverable from the client. It's just not a paid amount. But that was a cost reduction move that was done more than 10 years ago. Mainly because this crossover unit was growing quite rapidly at $5 to $10 million every biennium. So that was a way to kind of restrain that growth.
And Mr. Chairman, if I may add very briefly, we've talked about this program with JAC a lot in recent years, and the reality is this type of function is in the best interest of the state because, as Jesse mentioned, if we can essentially buy people onto Medicare to have their primary coverage be a purely 100% federal program, then we offset those costs of what would be, Medicaid expenditures. So those premiums that we pay for and cost sharing that we pay for is in the financial interest of the state. And we'll just double down on what Jesse mentioned, that years ago, seeing the growth in this program, folks will recall that that payment methodology that was changed to essentially reinforce that Medicare is the primary payer, and if they've reimbursed, then we're going to do a lesser of, was an important cost containment there. But I think this type of function for the dual eligibles is in the state's financial interest, so that Medicaid at 50% general fund is not covering the lion's share of that medical care.
Committee, anybody in the room? Anybody online? All right, just a couple more before lunchtime. Medicare buy-in premiums 450.
Chairman Pendergraph. So this is a large one. This is Medicare buy-in premiums. So what we do here is we're actually paying the premium on behalf of low-income individuals for Medicare. And so there's different levels of this. So there's qualified Medicare beneficiary, which is really a much lower income individual. We pay for those essentially 50-50 match rate. Then there's another group that we actually get 100% federal match on, it's a much smaller group that's higher income. We pay their premiums on their behalf too. So this is the Part A and Part B premium, as long as individuals qualified for those programs. So for Part A, they have to have a certain amount of working periods. But essentially, most people in Wyoming do qualify for both these programs. And if their income's low enough, this is a nice benefit to them that the state Medicaid program is paying their premiums for them. It can help, affordability and all those sort of things.
Committee? In-house. The opposite of in-house, nobody online. All right. Wyoming health insurance premiums, unit 451.
Chairman Pendergraph, unit 451, the health insurance premiums. So this, you can see it's a relatively small program. So one option we have in Medicaid is if it's cheaper to buy someone onto their private health insurance offered by their employer, we can pay the premiums on their behalf. And then we can pay their cost sharing through this program. So in some cases, and you can see it's not that common because Medicaid, at least as we've structured in Wyoming, is a pretty affordable option relative to private insurance. But in some cases, it makes sense for us to pay the premiums for individuals, and then they stay on their private insurance plan. So there is a calculation in statute that calculates what is affordable and when does this situation make sense. But there's some people that take advantage of this, and it makes sense for those families. It's a pretty small number. We've had actually a number of initiatives and staff members take this on as both a personal challenge and as a certified public manager project to try to increase this number and see if we could really push this. And really, with even sustained effort for multiple years, we were able to double the number, which sounds amazing, but it's still, it went from 10 to 20. So it just wasn't, most of the time when we do this calculation, it's just not financially beneficial to the state to pay that premium instead of just offer the health insurance directly, which is somewhat surprising.
Is it financially beneficial to keep checking? I have no idea what it costs us to go through this process over and over and over again. That's just a question.
Chairman Pendergraph, that's a great question. We might spend $10,000, $15,000 a year administering this. So I do think it's still cost neutral. We are required by federal law to have this and to make sure we explore this. I think in states with Medicaid expansion, we have seen that those states talk about this being a very important option to make sure you're exhausting the premiums with the disabled populations we have. Do they actually have employer-based insurance available to them? And is it affordable, or is it like 100% of the cost? And so I think that's the main issue, is that a lot of the individuals just don't have it available to them that is affordable. And, so in those other states, I think this is used a lot more. And, if you're a California or Florida or something like that.
Anybody in the room? Anybody in the digital room? All right, one more. This is Indian Health Services 471.
Chairman Pendergraft, this is labeled Indian Health Services 471, but it covers all the care that's provided by both IHS and the contracted tribal health organizations. So in Wyoming, and this is relatively recent, IHS has contracted with what's called 638 contracts with the tribes themselves to operate their own healthcare. So in either case, there's a federal encounter rate that we pay. That's 100% federal payment that we pay to, and that kicks in if somebody is a Native American and goes to a tribal provider. So it's not or, it's and. And so if a tribal provider, which does happen in some cases, serves a non-Native American, we just get the normal 50-50 match for those individuals. And we have a program which was used in a previous budget cut, which is called referred care. So if those tribal providers have a care agreement with a non-tribal provider and they are coordinating care with that non-tribal provider, we are still able to get 100% match. So when either of the healthcare systems for either tribe sends care outside of their community, but they have a tribal agreement in writing, and then they basically take those people back for primary care and care coordination after the care, we have been able to get 100% federal match for those individuals, for Native Americans as well. So it's a really great program. This also covers end-stage renal disease, which is a treatment clinic that they have on the reservation. There's also Morning Star nursing home, which is operated by one of the tribes.
If I read this right, no state funds are currently necessary. So we're just basically pushing.
Chairman Pendergraft, this is a 100% federal unit. We do have a pending 1115 waiver that was funded. It's been under federal consideration for 10 years. Given that may or may not ever be approved, we have made other adjustments in negotiation with the tribes and with the federal government's consultation to kind of accomplish the goals of that waiver. So there were some other changes made that helped increase funding for the same population. Okay.
Committee? Anybody inside the room? And nobody in the virtual waiting. All right, then we're going to break for lunch. We'll be back promptly at 1:10. We gotta have our full hour or we'll get grouchy.
Yeah.
So